I'll just like to share some housekeeping rules so that we have a really good time while we're here. Please let us put our phones on silent. Let us try not to have side conversations so we do not distract one another as we learn. Let us reserve our questions for the designated question and answer sessions. You can decide you want to hold the mic and share the spotlight with me, or you can decide to just write it down on a slip of paper and pass it on to me, and I'll pass on your questions to our speaker at the moment. Fire exits are marked. We have one over there and another exit that way. But most importantly, let's participate actively and learn from one another. So our journey today begins with understanding the scale of the challenge. Before we discuss treatment, we must first appreciate the burden. Before we discuss saving limbs, we must first appreciate the burden. Before we discuss saving limbs, we must understand why the limbs are being lost. It therefore gives me great pleasure to welcome our speaker, who will be giving us an overview on the growing burden of peripheral arterial disease in Nigeria and why early detection matters. Can I have her profile on the screen, please? Thank you very much. So Dr. Akeredolu Grace Adebimpe is a consultant cardiologist with a fellowship from the West African College of Physicians. She
arthritis, Rhoned phenomenon, some vasculitis, etc. There's a chart that shows the different risk factor. Now we have the non-modifiable risk factor, the modifiable risk factor, and some non-traditional risk factor. For the modifiable risk factor, that includes smoking, hypertension, hyperlipidemia, diabetes mellitus, obesity, sedentary lifestyle, hyperviscosity or hypercoagulable states, including pregnancy, or pregnancy-induced hypertension and pregnancy and gestational diabetes. Also, mental stress and depression are also modifiable risk factors. Non-modifiable include aging, family history of vascular disease, known coronary, carotid or renal atherosclerotic disease, chronic kidney disease, ethnicity, and also ex-smokers. So if someone had smoked in the past, the person is still at risk of having peripheral arterial disease. Now, other non-traditional risk factors include hyperhomocystinemia, elevated fibrinogen level, lipoprotein A, elevated C-reactive protein, and elevated ESR. For the pathophysiology, peripheral arterial disease usually involve atherosclerotic disease, affecting majorly the abdominal aorta, the iliac, and femoral artery. So basically, peripheral arterial disease just has to do with vessels outside the heart and the brain. Now, atherosclerotic plaque build up slowly on the inside of arteries. In the early stages of peripheral arterial disease, the arteries compensate for the plaque buildup by dilating to preserve flow through the vessel. However, eventually, the artery cannot dilate any further, and the atherosclerotic plaque start to narrow the arterial flow lumen. As the narrowing progresses or completely obstruct the artery, blood flow shifts to smaller arteries that parallel the diseased artery. Now, there are collaterals in the lower limb, which is not found in the heart. Although this collateral flow preserves distal perfusion, the network of smaller vessels never carries as much blood flow as the main artery. This blood flow restriction represents the hallmark of peripheral arterial disease and its typical symptoms. Next slide. The muscle of the lower extremities require increased blood flow during ambulation to meet the increased energy demand. So patients with peripheral arterial disease, they reach a point during walking at which collaterals blood flow is maximized and yet cannot provide any more perfusion to the lower extremity muscles. This supply-demand mismatch causes temporary ischemia of the muscles, which manifests as pain, cramping, or fatigue, and ultimately makes the patient with peripheral arterial disease slow down or stop walking. Next slide, please. Poor perfusion to the nerves can result in ischemic crest pain, which is often described as intractable burning pain in the sole of the feet. Non-healing wounds and ischemic ulcer represent tissue loss due to poor blood flow. In the most severe cases, the toes or entire forefoot can become black and mummified as gangrene develops. Most patients are asymptomatic. That is the picture for peripheral arterial disease. A lot of patients don't have symptoms. It is detected either by a low ABI, that's ankle brachial index of less than 0.90, or pulse abolition. The most characteristic symptoms of peripheral arterial disease is intermittent claudication, which is pain in the lower extremity muscle brought on by walking and relieved with rest. Although claudication has traditionally been described as cramping pain, some patients report some other symptoms like leg fatigue, weakness, pressure, or aching. So they can present with atypical symptoms outside intermittent claudication. Symptoms during walking occur in the muscle group, one level distal to the artery narrowed or blocked by peripheral arterial disease. Patients with aortoiliac artery occlusive disease have symptoms in the thigh and buttocks muscles, while patients with femoral-popliteal peripheral artery disease have symptoms in their calf muscles. The walking distance at which symptoms occur depend on multiple factors, including disease severity, walking pace, the terrain or topography of the area, and then the inclination being trekked on. Patients with severe peripheral arterial disease can develop ischemic crest pain. These patients do not walk enough to claudicate. So we have people who have severe symptoms, and even at rest, they have pain. And they don't even get to the level where they walk, and then they have intermittent claudication because of their severe disease. They complain of burning pain in the sole of their feet that is worse at night. They cannot sleep due to the pain and often dangle their lower legs over the side of the bed in an attempt to relieve their discomfort. So what happens? Blood flow under gravity, and then they feel better. The slight increase in blood flow due to gravity temporarily diminish the pain. Now, the clinical features. Patients with severe peripheral arterial disease can develop ischemic. Next slide, please. Now, so this is just two major classifications, the Fontan classification of the clinical presentation of peripheral arterial disease and the Rutherford classification. So basically, you have the stages and then the symptoms, and for Rutherford, we have the grade. For the Fontaine classification, the stage 1 symptoms, patient is asymptomatic. Stage 2, they have intermittent claudication. Now, 2A is non-disabling intermittent claudication, while B is disabling intermittent claudication. Stage 3, they have ischemic rest pain. That's a more severe disease. While stage 4 is ostration or gangrene. Now, for the other classification, the Rutherford, the grade A is asymptomatic. Now we have 3 categories under this one. There's mild claudication, there's moderate, and there's also severe claudication. So for the category 1, the claudication is mild, 2 moderate, 3 severe. While grade 2, they have ischemic rest pain, and then 5, they have minor tissue loss, while 6, they have major tissue loss. Next slide. So they can present on examination, they can have pain or tenderness on palpation, they can have pallor, the skin is pale, there's muscle atrophy. When you look at or examine the lower limb, there may be absence of evidence of loss of air. Then the skin may be cool and clammy. Then there could be absence of small volume pulses on palpation of lower extremities, arteries. Then the skin may appear dark or they may also have gangrene. Now, for the diagnostic approach, normally for clinical evaluation, there's a need to ensure that personal and family clinical history is assessed. This is very important, and the family history include history of coronary artery disease, cerebrovascular disease, aortic aneurysm, as well as lower extremity atherosclerotic disease. Now, the clinical history include the evaluation of cardiovascular risk factors and comorbidities, as well as the review of the symptoms related to different vascular territories. Lifestyle also is important. The lifestyle habit, the dietary pattern, the working performance, the physical activity, everything needs to be systematically interrogated. Now, along with this clinical evaluation, there's a need to do some baseline laboratory tests, which include lipid profile. And for this lipid profile, LDL is important, triglyceride is important, and it's also being quoted because lipoprotein A is a major risk factor, not a traditional risk factor, that this should be, assay, even if it's just once in a lifetime. Now, there's also a need to check the fasting blood sugar, the full blood count, the glycosylated hemoglobin. There's a need to screen for CKD, renal function for people who are not symptomatic, and also coagulation studies with liver function tests is important. Then there's also a need to assess for inflammatory markers, reactive protein, and then the ESR. Now, outside the initial assessment, there's also functional assessment, and this has to do with the treadmill testing using standardized criteria. So this treadmill testing is gold standard for assessing walking distance. So there are two main terms that are common when we do this test. One, patients are asked to indicate the point at which pain begins when they walk. That's the pain-free walking distance. So once someone starts walking, at what point did that pain, what was the distance at which the person experienced pain? Now, there's also the maximal walking distance when patients are asked to walk until maximum pain level is reached. So these patients walk until they get to a level where they cannot move anymore because of the severity of the pain. Now, it's also important to do a 6-minute walk test. This is also important to assess the functional capacity of the patient. Also, in addition, other quality of life tests can be done, and then the patient is also assessed for depression. Once we are done with the functional assessment, we go to the vascular imaging. Now, there are different imaging modalities, but the most common non-invasive imaging that is recommended as the first-line non-invasive test for screening and diagnosis of peripheral arterial disease is the ankle brachial index. And it is the diagnostic criteria is when the ABI is less than 0.90. In the case of non-compressible ankle arteries, or an ABI of greater than or equals to 1.40, additional methods such as the toe brachial index, the Doppler waveform analysis are also recommended. Now, ankle brachial index is inexpensive and minimally time consuming. However, it is not readily available in most centers. An ankle brachial index greater than 1.40 represents arterial stiffening, and it simply means that there's likely to be medial arterial calcification, which is commonly seen in patients with CKD, that's chronic kidney disease, in patients with diabetes, and it's also common in elderly patients. So who are those that should have an ankle brachial index measurement in clinical practice? Patients with clinical suspicion of lower extremity arterial disease. This could be when they present with lower extremity pulse abolition or an arterial brew. Typically also when they present with intermittent collication or symptoms suggestive of lower extremity arterial disease. Then when people present with non-healing lower extremity wound, they should be screened using an ankle brachial index. Patients are treated for lower extremity arterial disease because of the following clinical condition: atherosclerotic disease, such as coronary artery disease, and any other peripheral arterial disease. Other condition, aortic aneurysm, chronic kidney disease, heart failure should also be screened. Asymptomatic individuals who are clinically free but at risk for lower extremity arterial disease, which include men and women above 65 years of age. So it's been found that as people grow older, their risk of having peripheral arterial disease, the prevalence increases with increasing age. Now, also, men and women aged greater than 50 years with family history of lower extremity arterial disease should also be screened. Next slide. Now, this is just a picture showing how it is done. Now, basically for ABI, what is done is comparison of the upper limb, that's the brachial pressure, is compared to the ankle, which could be the anterior tibial artery and the posterior. So the lower limb arteries is the value, the pressure is divided by the brachial artery, and that is what gives us the ankle brachial index. Now there are categories for the grading of the severity of ankle brachial index. Now, if a patient has a value less than 0.90, that patient has less than or equal to 0.9, that patient has peripheral arterial disease. And now the grading, it's severe when it's between 0 to 0.49, moderate 0.5 to 0.8, mild 0.81 to 0.9, while the normal is usually between 0.91 to 1.3. Once it's greater than 1.4, then we need to screen for other causes of that can predispose to calcifications, like I mentioned earlier. Now, the other test that is done is the ultrasound scan, which is referred to as the duplex ultrasound scan, and is often a first step in the vascular workup, both for screening and diagnosis. Now, it detects and localizes vascular lesions and quantifies their extent and severity through velocity criteria. Now, this test is very sensitive. Its sensitivity in greater than 50% stenosis is 88%, while in patients with greater than 50% stenosis, the specificity is 95%. I'm running against behind schedule. So now other imaging that could be done is the computed tomography angiography. This is a test that has a short examination time with reduced motion and respiration artifacts while imaging vessels and organ. However, its drawback include exposure to radiation and then the use of iodinated contrast agent, which is limited in the case of CKD with precautions in cases of allergy. Then it's also the nephrotoxicity can be limited by minimizing contrast agent volume and ensuring adequate hydration before and after the imaging. Next slide. The other one, the next imaging modality is the digital subtraction angiography, which is considered as a gold standard reference in vascular imaging. It may be used in case of discrepancy between non-invasive imaging too. So if we need more definitive evaluation, this is what we need to go for. Next. Then the magnetic resonance angiography is used for peripheral arterial imaging using both contrast and non-contrast technique. However, MRI this magnetic resonance angiography could be impaired or is contraindicated in patients with pacemaker or high CD, and except for those who have MRI compatible pacemakers. And then it's also contraindicated in patients who are claustrophobic and in severe CKD. The limitation, it is limited in assessing patients with vascular calcification, potentially affecting vascularization procedure, and can be underestimated. Now, for endovascular stenting, magnetic resonance angiography is not used for this assessment. So in management, lifestyle modification, number one thing that is very important is smoking cessation. This is very, very important. Now, we also encourage regular physical activity, which is usually supervised. Healthy diet, increasing fruit and vegetable, nuts, legume in diet, and avoiding oily meals or fried meals. Weight loss, it is recommended that weight loss should be targeted to a body metabolic index of between 20 and 25. Then also it's important that the patient is properly educated on their clinical condition. Next slide. Now, other pharmacological therapy include antiplatelet therapy like aspirin or clopidogrel. Sorry? Okay, thank you. Now, antihypertensive is also important for people who have elevated blood pressure. So what is usually recommended is we can use ARB, that's angiotensin receptor blocker, or angiotensin converting enzyme inhibitors. Beta blockers are also used, and calcium channel blockers. For lipid lowering therapy, statins are used, and the target is to lower the LDL to less than 55 or 1.4 millimole per liter. Now, it's also important that we ensure that patients who are diabetic are well controlled. Now, for anticoagulation, it is indicated in some cases, in some scenario, especially post revascularization. So for revascularization, it could be indicated in severe or symptomatic cases. Options include endovascular procedures such as angioplasty or stenting, and then there could also be a need for surgical intervention like surgical bypass. Now, management of patients, there's another entity called acute limb ischemia, just like people have myocardial infarction, heart attack in coronary artery disease. This is the same, similar presentation in peripheral arterial disease, and the person just presents with sudden decrease in limb perfusion, which is threatening limb viability. The causes, it could be an embolism, a thrombosis, a trauma, or it could be secondary to an hypercoagulable state. The clinical features include CSPs, pain, pallor, pulselessness, paresthesia, paralysis, poikilothymia, that's the skin is cool. Then the management is emergency revascularization and anticoagulation. However, we don't do systemic thrombolysis in this case. Chronic limb threatening ischemia. This entity includes clinical pattern with threatened limb viability related to several fractures. So this is a chronic one. They usually present with ischemic rest pain, typically in the forefoot, with hemodynamic study, which will show ABI, ankle brachial index, usually less than 0.4, ankle pressure less than 50 millimeter of mercury, and toe pressure less than 30 millimeter of mercury, and then the transcutaneous oxygen concentration less than 30 millimeter of mercury. Now, they can also present with diabetic foot ulcer. They can present with non-healing lower limb or foot ulceration, usually greater than 2 weeks duration. Then they can also present with gangrene involving any portion of the foot or lower limb. So for this kind of patients, management basically, we want to control the risk factor, we want to treat superimposed infection, the risk factor, wound care, antibiotics if needed. We want to ensure that patients is, is evaluated for revascularization. If there is, if patients can have revascularization done, then they can, we need to assess, is there a need for amputation? If not, we just take care of the wound, we control the pain, and then we manage the risk factor. So for revascularization, it could either be the endovascular or the surgical intervention. Now, prevention and prognosis, there's a need for aggressive risk factor control, early diagnosis, multidisciplinary management. Peripheral arterial disease is not just a limb disease, it is a marker of systemic cardiovascular disease with high mobility and mortality. In conclusion, healthcare professionals and patients have historically underappreciated peripheral arterial disease despite its prevalence and clinical importance. This underappreciation seems multifactorial, e.g. limited availability of the first-line diagnostic test, the ankle brachial index in clinics, incorrect perception that leg vascular disease is not fatal, and that the diagnosis of peripheral arterial disease would not necessarily change clinical practice. Several studies have consistently demonstrated that many patients with peripheral arterial disease are not receiving evidence-based therapy. It is important to increase awareness and understanding of peripheral arterial disease, learn, improve diagnostic and treatment approaches to improve the prognosis of patients with peripheral arterial disease. Thank you for listening.
Don't go. Another warm round of applause for Dr. Adebimpe Grace Akeredolu for her wonderful presentation on giving us the overview to which lays the foundation for what we are talking about today, the growing burden of peripheral arterial disease in Nigeria and why early detection matters. Dr. Akeredolu, would you like to have a seat while we move into the question and answer session? triggering the inflammatory process. We talked about the burden of peripheral arterial disease, and we talked about the need for early diagnosis. How many people, what proportion, do you have an idea, are there documented
And then even when they are symptomatic, you know, let's say like 5 points, above 5% of the general population usually have peripheral arterial disease. And most people who have coronary artery disease or who have stroke, usually peripheral arterial disease, usually also are predisposed to having peripheral arterial disease.
Okay. Thank you. So right now, we really do not have the data to guide us on even making policy decisions about peripheral arterial disease. And so that brings me back to home and this room. I think it's very important because we have quite a number of healthcare leaders, healthcare professionals, different disciplines in the room. And I think the message is quite loud and it's quite clear. For us to make proper decisions, it's very important that we have the data. And before we can have data, we actually have to do the research. So, and before we can do the research properly, then we need to collaborate. And I think that's one message for this room moving forward, that we need to come together as healthcare professionals who are passionate about peripheral arterial disease and see how we can go about conducting these researches in Lagos and in different parts of the country so that we can generate data that supports policy change regarding peripheral arterial disease. So I'll just ask this last question. Which patients should be screened routinely? You mentioned that over 50% are actually asymptomatic, meaning they do not present with symptoms and so will not come to the hospital and say there's something wrong with them. Who are the people who should be screened routinely for peripheral arterial disease?
Was presenting people with vasculitides, people with diabetics, smokers, people who are hypertensive, who have coronary artery disease, who have had stroke in the past, because once there is some form of, you know, a vascular, cardiovascular event, it's the same mechanism. It will affect the lower limb vessel too. So such people also should be screened for peripheral arterial disease. Now, for based on the research and the studies that have been done, normally above 50, I think men should be screened. Men, you know, are predisposed, older men majorly. So, but as they grow older, above 70, the prevalence also increases. So men above 50, including women though, and then people who are diabetic, people who have chronic kidney disease. These are people that should be screened for peripheral arterial disease.
Thank you very much, Dr. Adebimpe Akeredolu, for your presentation once again and for gracing us with your presence and answering our questions. A very warm round of applause for Dr. Akeredolu as she steps off the podium. And so, from the presentation, we can see that there is a growing challenge that affects millions of people worldwide and increasingly many Nigerians. And one message stands out. Peripheral arterial disease is common. Peripheral arterial disease is underdiagnosed, and it often is detected too late. The encouraging news, though, is that, yes, some of the investigations at some point in time were not readily available. but now we have them. Some of the interventions were not readily available, but now they are available. And that is the good news that we bring to this room today. And we hope that we can spread from this room today that these investigations are available. Ankle brachial index is available. Endovascular revascularization, it's available. And for this, we move on to the next part of our program to talk more about the different aspects, the multidisciplinary aspects of managing peripheral arterial disease. It's very important that we note that it is not a disease that can be tackled by one specialty alone. It requires collaboration, the collaboration of family physicians, the collaboration of endocrinologists, the collaboration with cardiologists, surgeons, vascular interventionists, nurses, wound care specialists, physiotherapists, and healthcare institutions. We must all work together towards a common goal. And so to help us explore this journey, we have assembled an outstanding panel of these people who are experts in the field, and I'll be welcoming them to the stage shortly. Please could you assist me to set up the stage? While they do that, I will acknowledge the presence of Dr. Ronke Akirele. You are highly welcome, ma. Please stand up. Thank you so much. You're welcome. Thank you, ma. Yeah, that's fine. Thank you so much. So can I have the profile of my first panelist, Dr. Adeboyega Alao? So I'll be welcoming the first of my panelists. Dr. Adeboyega Alao, our first panelist, represents the front line of healthcare delivery. Dr. Adeboyega Alao graduated as a medical doctor in 2009 from Ladoke Akintola University of Technology, Oyo State, and completed his residency program at the University College Hospital, Ibadan, to become a fellow of the West African College of Physicians in the Faculty of Medicine. Dr. Alao holds a certification in leadership and management in health from the University of Washington, USA. He also obtained a certificate of competence in travel medicine from the University of Witwatersrand, Johannesburg, South Africa. Dr. Alao is a member of the Society of Family Physicians of Nigeria and the Nigerian Society of Travel Medicine. He was awarded the Best Senior Registrar in the Department of Family Medicine in 2019. Please, with a warm round of applause, welcome Dr. Adeboyega Alao to the panel session. Thank you, sir. And I would like to present the next panelist, Dr. Francis Asogwa. Our next panelist is a consultant cardiologist. He trained at the Alex Ekweme Federal University Teaching Hospital. Previous slide, please. Oh. Is this the first one? Yeah. Dr. Francis Asogwa is a dedicated medical professional with over 17 years of experience in the healthcare sector, specializing in preventive cardiology and interventional cardiology. His journey in medicine began with a Bachelor of Medicine and Bachelor of Surgery degree from the prestigious University of Nigeria, Nsukka, in 2006, and it has since evolved into a passion in preventing, diagnosing, and improving patient care. He's a fellow of the West African College of Physicians, fellow interventional cardiology and vascular intervention of Indraprastha Apollo Hospital, New Delhi, India. He has a master's degree in health policy and health systems from WHO certified health policy and health systems, Emory State University. Next slide. He trained at the Alex Ekweme Federal University Teaching Hospital, Abakaliki, where he acquired administrative competencies as chief resident in internal medicine, secretary of the Association of Resident Doctors, and secretary of the Nigerian Medical Association, Ebonyi State Branch. He's an active member of the Nigerian Cardiac Society, Faculty of Internal Medicine, West African College of Physicians, Nigerian chapter, and the European Society of Cardiology. Please welcome Dr. Francis Asogwa to the panel session. And now I will be welcoming to the stage Dr. Ekido Opiabele. She will be representing endocrinology. She's a highly respected consultant endocrinologist at our Iwosan Lagoon Hospital's Ligali branch. With a deep focus on endocrinology, her journey in the field of medicine began with a bachelor's in medicine and surgery from the University of Benin, culminating in her recognition as a fellow of the West African College of Physicians in November 2017. Throughout her career, she has consistently demonstrated expertise in the field of endocrinology and upheld a commitment to providing exceptional patient care. Her previous roles as a consultant physician and endocrinologist at Rainbow Specialist Medical Center and as a senior registrar at Delta State Hospital has enriched her clinical knowledge and contributed significantly to patient care, as she previously served as a senior registrar at the prestigious University Hospital. Please welcome Dr. Ekido to the stage as one of our panelists for this session. Thank you. And coming to the stage now is Professor Bolaji Mofikoya. He's a burns, hand, and plastic surgeon. His undergraduate training was at the College of Medicine, University of Lagos, while his postgraduate training was at the Lagos University Teaching Hospital, Idiaraba. He's a fellow of both the National and West African Postgraduate Medical Colleges. He further had subspecialty training at the National University Hospital in Singapore. He has undergone further trainings in Germany, South Africa, Taiwan, and the US. His areas of interest are general reconstructive surgery, hand surgery, and complex wounds. He has been involved in undergraduate and postgraduate training over several decades and brings a lot of experience to patient care. You're very welcome, sir, to the stage. Thank you, yes. Yeah, I should be in the window. So, thank you very much for honoring us with your presence and your expertise as we go into the next session. And this is our panel session where we'll be exploring the patient journey together. It's very important that we understand how these affect the people that we care for. So, to guide this conversation, I'd like us to imagine a patient. Perhaps a 58-year-old Nigerian living with diabetes and hypertension. And this patient starts to notice pain in his leg whenever he walks. He begins to notice the pain, but he ignores it. Months later, a wound develops on his foot. The wound refuses to heal. Eventually, gangrene develops. And suddenly, he is told that amputation may be necessary. The question before us today is, could we have changed that story? So let's move into this journey together. Let's identify the patients who are actually at risk. Dr. Ekido, who are the patients we should be most concerned about? Who are the patients in our clinics that most at risk of developing peripheral arterial disease?
Good afternoon, everyone. So for the patients with, I'm talking as an endocrinologist, and the patient with diabetes, it's been said about 1 in 3 patients with diabetes has or would have peripheral arterial disease. Unfortunately, they are always the late to present, because just like with diabetes, presentation of PAD is usually atypical. So yes, they can present with pain, but most of them will present without pain until they develop that ulcer. Diabetes education is taken as a very important part of diabetes management. And we must always inform, educate, enlighten our patients every time they come to the clinic about the symptoms, about signs, in fact, about diabetic foot examination. It's what they should do every day. They should look at their feet. They should inspect their toes, in between their toes. And in fact, so it really starts with the patient being informed and being motivated to be able to, take charge of their management. So that is how we can prevent or avoid such late presentations, particularly in patients with diabetes.
Thank you very much. I hope we've taken note of that. It's very important. 1 in 3 diabetic patients, 1 in 3 diabetic patients could develop peripheral arterial disease. And most times it is asymptomatic. And so it's important that we start with the discussions in the room on identifying the risk factors. So I move on to Dr. Asogwa. Many people think that, thank you. Many people think that peripheral arterial disease affects only the legs. How closely linked to peripheral arterial disease is to heart attacks, to strokes, and the overall cardiovascular disease?
All right, thank you. Peripheral arterial disease, like cardiovascular, is a kind of cardiovascular disease, and they share a common risk factor. And these risk factors, part of what we've discussed today: hypertension, diabetes, hyperlipidemia, smoking, obesity, and advancing age. So there's a relationship between cardiovascular, a heart attack, or what we call coronary artery disease, and limb ischemia. In fact, as the lecture was going on, I was discussing with my colleagues that we have what we call leg attack. As we have heart attack, we also have a leg attack. So the leg attack is the acute limb ischemia, just as we have acute myocardial infarction. So most of my patients that have acute myocardial infarction or coronary artery disease, I also recommend that we look at the legs. So it's very important. So as general practitioners, as physicians and clinicians, whenever you see a patient with hypertension or coronary artery disease, it's also very important we check the legs by simply doing an ankle brachial index. So an ankle brachial index will give us an assessment, especially for patients that have the risk factors. And we've listed the risk factors. So it's very important that as we have heart attack, we also have the leg attack. So thank you.
Thank you very much. Dr. Alao, our doctor of first patient contact. Since many patients first present in the primary care settings, what symptoms immediately should raise suspicions of peripheral arterial disease?
Okay, thank you very much. So in primary care, we see all kinds of patients with, lots of symptoms, but there are some symptoms that should, really raise an alarm, whenever we encounter them. And such symptoms include leg pains, especially when the patient is presenting with intermittent claudication, reduced exercise tolerance, they can't walk, an average distance that one should be able to walk normally and without having leg pains. That should raise an alarm. Some other symptoms that these patients present with in outpatient clinics. It could also be poor wound healing, maybe some chronic leg ulcers. That should also raise some suspicion of peripheral arterial disease. Even erectile dysfunction, because it's hot, like Dr. Sogwa said, it's usually systemic disease, not just a localized disease in the leg. So patients with erectile dysfunction, we should be able to assess, further if the legs are also involved, whether there's some atherosclerosis going on. DM foot, it's been, well emphasized already. These are just a few of, some symptoms that should raise an alarm whenever we encounter these patients.
Thank you. And so, sorry, still to you, Dr. Alao. As I said, you're a doctor of first patient contact. And as we said, quite a number of people present with these symptoms that, are often overlooked. Now, when we are actually able to identify that these symptoms might be a pointer to peripheral arterial disease, what are those practical, screening methods, screening measures that every healthcare professional, even at the most basic level, should be able to implement, to identify, and then escalate if necessary in such patients?
Okay, yes, thank you for the question. So whenever we identify especially high-risk patients for PAD, we should be able to do a very good detailed screening, or even a focused history taking. Cardiovascular history is very important. The screening starts from there. Especially if the patient is hypertensive or diabetic or a smoker, these are very high-risk patients that we should pay particular attention to. And so our screening should involve detailed or very good history taking, blood pressure measurement, accurate blood pressure measurement, to be able to determine, in patients who have never been diagnosed hypertensive, and then maybe presenting with elevated blood pressure at the clinic. Then we also have a foot examination. It's very, very important. Most times, maybe because of our busy clinics, we tend to overlook that. We just gloss over it. But it's very, very important. Routine foot examination is very, very important. And then we go on to laboratory screenings, blood sugar checks, lipid profile. These are pointers. These are things that can, point us in a particular direction to be able to pick these patients early. Yeah.
Thank you very much. So from what you said now, something as simple as just checking for the pulses in the foot, the dorsalis pedis and the posterior tibialis could actually just point us in the direction of peripheral arterial disease. I hope we're all hearing that in the room. So in our busy clinics, let's take out the time to just, especially in our patients who are diabetic and hypertensive, and when they do complain of leg pain, to just take out the time and examine the foot and check these pulses. And this might just be a pointer to peripheral arterial disease and further evaluation. Dr. Ekido, as we mentioned now, dorsalis pedis, posterior tibialis, how important should routine foot examinations be in the diabetic clinics?
Thank you very much. I just want to say diabetes is a vascular disease. It just exerts most of its complications through the vessels. We have microvascular complications and the macrovascular complications, where peripheral arterial disease is one like stroke or acute coronary syndrome, the heart attack. Guidelines say that for patients who do not have evidence of peripheral arterial disease or neuropathy, you could do your annual foot examination. For those who have peripheral neuropathy without PAD, you need to do maybe every 6 months. And then those who have both peripheral arterial, well, the second one is either or, peripheral arterial disease plus peripheral neuropathy, then you should do every 3 months. And for those, of course, who have visible ulcers or ulcers that have healed, you need to do as often as every time they show up in the clinic. So it's not a one-size-fits-all, but annually for everybody, and then you now stratify accordingly. So those who have peripheral arterial disease, those who have peripheral neuropathy, those who have ulcers, those who have already had lower limb amputations and all that, you may need to do more frequently.
Thank you very much for that response. So, Prof, what wound characteristics would actually be a pointer that it's not an infection and possibly make us suspect that there might be some poor circulation going on in a wound that is not healing or a chronic leg ulcer?
All right, thank you very much. Well, when eventually the patient gets sent to us, already it's late, really. But many times, what are the things that we look out for? Ulcerations that occur commonly in the distal foot. The commonest site of the regular chronic leg ulcers tend to be in the lower third of the leg. Many of the arterial ulcers tend to occur in the foot and commonly starts on the toes. They start usually very insidiously. Normally, you expect the foot to be able to, normal healthy tissue to be able to withstand minor trauma, minor incidental trauma. You bump your leg against a chair and it shouldn't result in a wound that continually persists for over several months. When these occur, we should draw our attention that something may be wrong. While attending to regular wounds in the lower extremity, and we observe wounds that, in spite of all the agents that are used, debriding agents, sclerotic agents, agents that promote epithelialization, these wounds don't respond to any of these things. You should think about a vascular ulcer of peripheral arterial disease. Now, speaking generally also to people who even operate, surgeons, sometimes recommendations are made that, oh, this wound is quite bad. This wound should have a debridement, a surgical cleaning. But alas, when you do the surgical cleaning, a few days later, it's as if the wound was never touched. All these point to the fact that there's an underlying vascular pathology that needs to be addressed. I'm really glad that we are discussing these because it is quite topical. And we have observed that the indication for amputation in the country has dramatically changed. Now, majority of amputations are due to non-communicable diseases, hypertension, diabetes, peripheral arterial disease. Where I work, they outnumber trauma by about 5 to 1. So essentially, it is really an epidemic. I know that Diabetic Society talks about 2 to 5% of Nigerians are diabetic. Let's translate that to 250 million. We're talking about over 10 million people. Many of them are not symptomatic. Just before I came, I still saw a lady with a pre-gangrene. The pain is now intractable. And that's probably only the tip of the iceberg. So I really want us to take home that message and disseminate that information, because whether when we detect them early, then these measures can actually work. And we can benefit the society, because the burden of this is quite significant. Thank you.
Thank you very much, sir. And so what this points us to is that if we wait until gangrene develops, it means that we've missed several opportunities to actually intervene. At what point, Dr. Alao, should a clinician stop treating conservatively? Stop using the escharotic agents? Stop using debridements? Stop using the antibiotics? At what point do we make that decision to refer the patient for specialist input?
Yes, thank you. Certainly when all conservative measures are failed. So the patient has to be referred to a specialist vascular physician or surgeon. I have a list of, things here regarding indication for referral, for specialist vascular input. The first thing is what I mentioned, when conservative measures are failed. Second is lifestyle limiting, claudication. Patient cannot really move, and a considerable distance before he or she starts to have leg pain, or even when the patients are having pain, even at rest, it's becoming worse. It all depends on the stage at which the patient is presenting to the doctor, because some patients present late. But it's very important that they are picked early, by actively looking for these signs and symptoms in patients, especially when they have diabetes, hypertension, when they're smokers, when they are obese, or they don't engage in physical activity enough. So we should be able to look out for these things. The other things I have here we already mentioned that during the lectures. Chronic limb threatening ischemia. That's when the patient starts to have pain at rest, non-healing ulcers in the leg or gangrene, severe hemodynamic compromise, absent pulses in the legs, very low ABI, that's acute brachial index, and or absolute hand-core systolic pressure of less than 50 millimeters of mercury. So basically, these are the things that are mentioned here. Okay, acute limb ischemia is another thing. It was also mentioned during the lecture. Characteristic features of pain, pallor, paresthesia, poikilotamia, and all that.
Yes. Yeah. Thank you very much. And now, Dr. Asogwa, when we get to the point where gangrene has developed, like you mentioned, by the time we have the ulcer, it's not healing. You actually try to convince the patient to go for the specialist intervention. They probably are not convinced that they need the specialist intervention, or it's not readily available even when they are convinced that there can be a difference. When we get to that point, how important is it? How do we go above and beyond as clinicians to explain to our patients the importance of restoring blood flow to such limbs in preventing amputation?
All right, thank you very much. Going beyond amputation, as a cardiologist, I tell my colleagues that we don't even have to wait for the wound to appear. So if you have any patient that have, discoloration in the legs, pain in the legs, it's better you refer the patient to the cardiologist. Now, why do you refer to the patient to the cardiologist? It's been shown that 70 to 80% of patients that have peripheral artery disease also end up having coronary artery disease. In fact, there was a procedure we did with my professor, Professor Badero, a patient that has peripheral artery disease. So we gave him the statistics that there's a possibility for coronary artery disease. He said, no, just my leg. So we convinced him. Eventually, when we finished with the leg, we went to the coronary artery, and lo and behold, the patient had a triple vessel disease.
Wow.
Requiring surgery.
Wow.
A bypass surgery.
Wow.
He didn't come with chest pain. He didn't come to us with anything coronary. He just came because his legs are paining him. And so we convinced him on the table. And Prof is here. So after the procedure, we discovered a triple vessel disease. And we told him, okay, you will require a coronary bypass surgery. So he was surprised. So that tells us that peripheral artery disease is more like a window to the heart. So we don't allow a patient develop. If a patient start having chronic wound and all that, something sinister is actually going on in the heart. So let's start to get them. So the very essence of this gathering is so that we can quickly, as soon as possible, refer them to the cardiologist so that they can have complete cardiac workup, stress ECG, stress echo or echocardiogram, so that we can look at the heart too. So many of them end up with coronary artery disease. All right. So people don't understand that one of the commonest cause of like Prof said, non-traumatic amputation is peripheral artery disease. A lot of people are getting amputation because of peripheral artery disease. And so beyond amputation, we also look at the heart. Okay. So amputation may not kill, but the coronary artery disease will kill. So we advise every patient that has peripheral artery disease to go for a cardiovascular assessment.
Thank you very much, sir. A round of applause, please. We're getting free, hot information here. Dr. Ikido, we're looking at building integrated pathways. Yes, we've identified, our patients. Yes, we've convinced them. We've tried the preventive pathway. Some slip through and develop the ulcers, the gangrenes, and then they're there where we have to make these hard decisions along with them. But we know that if the pathway to care is actually more cohesive, a lot of these patients will not end up at this point. What would an ideal patient pathway look like? From screening to specialist care, and how can diabetic clinics collaborate more? Yes, most hospitals, at tertiary level have diabetic clinics. How can we collaborate more across facilities, across specialties, to ensure that the people who need this care actually receive it? What would it look like from, screening, and then how can we start working towards creating that pathway that allows the people who need this care to actually access the care?
Thank you very much. So, like I said, it starts again with information, education. The patient with diabetes needs to be informed, needs to know about the symptoms and signs, and it starts with them identifying after they have been explained or taught in the clinic about what they should look out for, so that by the time they get to it doesn't end up with an ulcer. They already have the tingling sensation, all right? They already have, they're already inspecting and looking at their feet every day or every morning for, just like Prof said, a wound they didn't even note, a blister that develops. So it starts with the patient, and the patient comes to the clinic. The doctor does what I call the detailed foot examination, examines the the skin, the toes, joint deformities, examines the pulses, and then goes on to do ABI, the ankle brachial index. Just like diabetic patients are atypical, most times the ABI may be normal or even high because they have calcification and they may have ABI greater than 1.4. And so we have seen even as recently as when I see patients in the clinic and they have done an ankle brachial index and it's come out as normal. And we do the Doppler, and the Doppler will say, we'll go on and say mild or moderate peripheral arterial disease, and I will send to Dr. Asogwa, Dr. Asogwa, and then we send to Prof. And the next thing is that, like I saw the patient the other day, he says, "Oh, I've been on admission for 4 days," and it was like within a week that I had said, go and see the interventional cardiologist. For this seemingly like was pain in his feet, and he ended up having a procedure for an ankle brachial index for a patient with diabetes that was normal. So for us, well, like I said, because we have an integrative process, it's not the same out elsewhere. And so we have tried to, I think that's one of the purpose of this meeting, to be able to raise awareness. We, in the Diabetic Association of Nigeria, that's also being done, because diabetes is the #1 cause of a non-traumatic lower limb extremity amputation everywhere in the world. So it's very important for us as people managing diabetes, because I'm sure if everybody here may probably know somebody who has had an amputation, and it's mostly a patient with diabetes and all that. So yes, it starts with even the family physician sends to the patients to the endocrinologist or diabetologist, and gets sent to either the cardiologist or vascular surgeon. We have tried to, I think that's also the purpose, to preserve limbs, and that is what the purpose of this presentation is, on how we can preserve our patients' limbs, because it is actually a preventable condition.
Thank you very, very much. Well done, ma'am. And so my last question goes to you, Prof. What would a salvage team look like in the ideal world? Because that's what we're trying to create now. If we were to put up a team together to champion this cause, what would the ideal salvage team for peripheral arterial disease, saving limbs, saving lives, what would it look like?
Thank you very much. I think it probably will be start with the family physician. Start and end with the family physicians. Because if patients come from the family physicians, patients will see the family physician much more frequently than he will see the interventional cardiologist, okay, or the surgeon, or the endocrinologist. Will include the cardiologist. Without life, there is no limb. So we'll include the endocrinologist. We'll include the interventional cardiologist. We'll include the support groups. I am aware that Iwosan Lagoon has a diabetic support group. And one of the things we can do is to work with that support group. Many times what all that we've said here, you need to get the buy-in of the patient. We really need to get the buy-in of the patients to make them see the overall benefit of such. We need to involve a vascular surgeon. I'm sure we'll get to that. They need to highlight identify patients who will benefit from some intervention. Okay, because not all patients may benefit from intervention. But if we are able to identify them early, we probably will be able to identify more people and salvage more limb. Of course, you are going to need the plastic surgeon. You are going to need the nutritionist. You are going to need the social worker. People need to engage these people sometimes in the communities. Those will help to maintain whatever you have gained. Let me give a scenario. Few days ago, we saw a patient who had had an amputation of a limb 3 years before. And usually what, as Dr. Ekido has said, ideally such a patient to have a more frequent assessment. You really need, you can drive that as a physician, but patient needs to understand that if you've had one limb amputation, the chances of having the other limb amputated is, I don't know how high that is. And that was emphasized. Few years down the line, we are back with a mirror pathology in that particular limb. So we really, as I said, we really need to get in the patient's buy-in. We need them to understand we are on your side and we want the best for you. And I think this is probably an excellent opportunity to disseminate that and to develop an integrated team, not just for salvaging limbs, but for saving lives as well.
Thank you very much. And this brings us to the almost end of this discussion, and then I will throw it open so that people who have things to contribute will surely go ahead and share the spotlight with me, as I said earlier. So I'd like each of the panelists to give us one practical action point every healthcare worker in this room can immediately implement to help save more limbs and save more lives. One practical action that people in the room can take away and start implementing in their clinics. Ladies first.
I think maybe to screen for diabetes. Maybe. Yes. Maybe to just first screen, because 50% of people with diabetes don't know they have diabetes. And unfortunately, sometimes a limb amputation may just be the first clinical presentation of a patient with diabetes. So I know it's kind of far-fetched, but even if we do our just routine checks and just screen ourselves for our blood sugar, that can just be a start. And then in our clinic, talking to our patients, diabetic clinics take a long time because you have a lot of patients. You have patients where you have to tell them don't do a whole lot of things that other people can do, and so you need to, just like Prof said, motivate people. My teacher at the University College Hospital where I trained in Ibadan used to say that the diabetic foot or feet was like a woman's face, and they needed to look at it the way they will look at their face. So we tell our patients, your feet is your face, a woman's face. So treat it the way you don't want anything on it. You want to, so that's what I would tell my patients.
Well, one key thing that I will tell everybody to do, examine the peripheral pulses. Feel the pulses. I know they are not very, we don't want to do that many times. The dorsalis pedis, the anterior posterior tibial, and the ankle brachial index. Those are very simple things we can do anywhere, and they tell a lot.
Thank you. Yeah, so in line with what Prof has said, touch your patients. Feel the peripheral pulse is very, very important. And for us cardiologists, please, every patient that you think has a cardiovascular risk factor, do an ECG for us. Yeah, so in fact, when I came into Lagoon Network, I had to emphasize it. In fact, we have an ECG platform. Those of us that are in Ikoyi here, every ECG must be placed on that platform. And if I don't respond in 5 minutes, just give me a call. So the ECG is a window to the heart. All right, so thank you.
All right, so as a family physician, in addition to all that they said, touching the patient, checking the feet, the pulses you have to check. It's very important that the modifiable risk factors are, well taken care of. All the factors, none is less important. So the lipid control must be good. Glycemic control must be good. Blood pressure control must be very good. This will help us prevent peripheral arterial disease. Thank you.
I'd like a very, very warm round of applause for each of my panelists. They have done more than justice to the topic today. And before we allow them to step off the stage, I'd like to throw open to the people in the room for quick comments, short, quick comments, because, as usual, we're running behind time, so that we maximize and create adequate opportunity for our keynote speaker to deliver a fantastic presentation. So please, very short comments. We'll take 2, and that will be it. Can we see?
Good morning, everybody. It's afternoon now, sorry. Good afternoon, everybody. My name is Osan Hoy, a person with type 2 diabetes. Thank you very much. Though I came in late, my car broke down on Third Mainland. Sorry about that. I want to thank Dr. Kidu for letting me know about this wonderful, wonderful meeting. And on behalf of people living with diabetes, I say thank you to Lagoon Hospital for organizing this. I think we should clap for them. This is what we need. And the WHO, this is what we need. That's what we are talking about, it's conversation on the table. This conversation is very important. I just want to say thank you first, but I also want to add that the sermon has changed. The sermon is, just want to add to what the family physician said, and also correct some things that you don't need to wait. Everybody, because they asked a question, at what point do you refer? You don't refer, you co-manage. At the point you have a person complain about anything that has to do, you co-manage, because you don't let go completely. That's the sermon. So the person, because the patient may be used to you, and his problem is not going to be like for the person you're referring to completely. So you co-manage and you have that conversation. That's the new way, and that's how we who are living with the condition feel comfortable. So thank you, and I know you will do better than that. Thank you. And the cardiologists, thank you very much. That is the fact, because recent research shows, because I was diagnosed early this year of peripheral arterial disease, and it shocked me, because I've been doing peripheral neuropathy, all the community screening. I'm number 1, they screen first. I know I had mind sensation defect, or what you call neuropathy, and advocate. I run everybody here, most of you know me. That's my passion, to correct limbs, to salvage limb. But nobody, Dr. Ikido, you know you're my darling. Nobody, until I met this endocrinologist, when she jackpot to this place, because she's been my doctor, asked me to do arterial pad, to do pad. Let me use this short language. And when they checked it, I was shocked because I slept off on the table when the man was doing the screening. It was so long. I've never had such training. And I slept off. When I woke up and he told me, I have a mild disease. That is sad. Because he said you are supposed to be doing it. When I went back, I said, why is nobody asked? So we are supposed, for every patient that is diagnosed of diabetes, once a year at least, you check. Thank you for jackbarring. I wouldn't have found that out. Thank you for that information you gave to us.
Thank
It's the
you,
truth. So, but the other thing I want to correct, sorry, please, this is very important, please, because to have this number of Nigerian doctors gather in one place is not easy. They faithfully came. Look at, there are so many. I can't remember the last time, apart from ENSO, that you get them gathered like this. Kudos to you. Thank you, honestly.
Very much.
So please, let me talk to them. Please, I beg you. This is important, the conversation that was had here. The plastic surgeon has spoken. Today, they are the ones salvaging the limb. If you don't have, please, I beg you, what he has said here. And the team that we are to have, you missed out psychiatric doctor. Yes, we need them. You missed out physiotherapists. We need them. Because in my support group, all you have mentioned, they come. We partner with the podiatrists who have been coming to Nigeria for the past 8 years to join team with Nigerians to educate them free of charge. We have not gotten support so much. But thanks to what Lagoon has done now, I guess the next time the team is coming, we are visiting you first. And in case you are interested in your hospital, please let us know. They have been coming to talk to Nigerians, to train. We even have interventionalists on the team for more than 8 years. Dr. Isiawe was championing that. So please, I beg you, add those two people because they do wonders with our legs, our health. Dr. Ikidu, thank you very much.
Thank
God
you very
bless.
much. A round of applause. For lack of time, we will need to cut.
Just a minute.
Okay,
Thank
just
you very
that
much.
minute, sir. Thank you, and that will be our last
I'm
comment.
Dr. Oladipo Anoma.
Nice to meet you.
I'm to
Welcome,
private
sir.
practice. Let me appreciate my friend Dr. Adebayo for inviting me.
Thank you.
You know,
Welcome.
I must appreciate Lagoon again. Ever since we have economic problem in Nigeria, we only have an organization calling doctors, arranging this program like this again. You know, things are actually affecting everybody. We really appreciate the program. What I would just have to say is just a clinical presentation, a second. Those of us that were used to watching football, we know about football. Remember our coach in Nigeria, Stephen Keshi. He had a pains in the leg, little swelling. And what we do in Nigeria, you know, invited the local people to come and massage the leg. And it was done. Few hours later, he slumped, he died. So now, what do we do? Most of the challenges in Nigeria, problems, before they come to doctors, they invite local people. In my practice in my area, almost about 90% of pregnant women will go to the TBS. That's the problem. You end up with ruptured uterus, obstetrical labor nearly every day. In your own case, what can we do for the people, the masses, to know? So that when you have this problem, instead of going to the local people, come and see the doctors so that the problem can be solved on time. Thank you very much.
Thank you. And so with this, we wrap up the panel session. Thank you. Another warm round of applause for our panelists as they step off the stage. and we proceed to the tea break, and then our no, after please. Thank you. So 5 minutes for the tea break, and the next part of the program commences. Thank you. Just to allow sir. No wahala. Before you go, thank you very much. And so I would just like to use this opportunity to, yes, to sit, yes. Yes. So please, let's be seated while the tea break is served. Thank you. I'd like to use this opportunity to warmly welcome the President of Medical Women Association of Nigeria, Lagos branch, Dr. Imefimdom Imedimfa Oko. Thank you so much for honoring us with your presence, ma'am. We know how busy you are. Thank you for being here, and we hope that you will take the message across that we at Iwosan Lagoon hospitals, we are very ready to collaborate across facilities to ensure that we save limbs and we save lives. Thank you very much. I'd also like to use this opportunity to warmly welcome our MD, Iwosan Lagoon Hospitals, Idejo branch, Dr. Tomi Kogo. Thank you very much for honoring us with your presence, ma'am. You're welcome.
Let's just talk about it then. We'll not get right to the next. What do you want me to say about this? So what's going to happen? We're just going to say something that yes, I say yes. Say, oh, that's good. Are they partnering with us? They're not partnering. Professor Badero, does he have any problem with us starting while people are still eating? No, I don't. Let me ask. Do you understand? So we can call the room to order, and then, do you understand? What do you mean about James here? No, we just want to help us make sure that James.
table. I'm going to collect another one.
Thank you, everybody. Could I have everyone in the room seated, please, as we move on to the next session? Ladies and gentlemen, and we are in the afternoon. We have discussed who is at risk, how to detect peripheral arterial disease early, when to refer, when to co-manage, and how multidisciplinary collaboration can improve outcomes. I would like to introduce our next speaker. And it gives me great pleasure to be a part of the team, of the organization who is bringing this to the healthcare space in Nigeria. He's well known to some of us and well known to quite a number of people for his achievements, which I will be speaking to shortly. Professor Ourotimi John Badero is a globally renowned physician, recognized as the world's first and only board-certified interventional radiologist. Sorry, cardio-nephrologist. My bad. I apologize, sir. Once again. Who am I? Combining expertise in both heart and kidney care. Rare accomplishment that distinguishes him among physicians worldwide. Okay. And so, you can see that Iwosan does not play when it comes to first-class healthcare. With another warm round of applause, I welcome Professor Ourotimi Badero to the stage to talk to us today. You're welcome, sir. So we seem to have some technology issues. And I have to read it all. He has been inducted into several prestigious professional and academic societies, including the Fellow of American College of Physicians, Fellow of the Medical College of Physicians, Nigeria, Fellow of the American Society of Nephrology, Fellow of the National Kidney Foundation, Fellow of the International College of Angiology, Fellow of the American Society of Diagnostic and Interventional Nephrology, Fellow of the American Society of Nuclear Cardiology, Fellow of the American Society of Angioplasty, Fellow of the American College of Cardiology, Fellow of the Society for Cardiovascular Angiography and Interventions. Since 2015, he has actively contributed to reversing brain drain in Nigeria through lectures and medical training initiatives at Obafemi Awolowo University as well as University of Lagos. His numerous honors include the Obafemi Awolowo University Global Award for Excellence in Medicine, the Distinguished OAU Alumni Award for Professional Excellence, the ANLL Presidential Award, the Most Purposeful Healthcare Person in Nigeria Award presented by Olusegun Obasanjo, and Mississippi Healthcare Hero Award. In 2023, Professor Badero expanded his impact in Nigeria through Iwosan Lagoon Hospital, where he serves as Chief of Interventional Cardiology and Director of the Cardiac Catheterization Laboratory. There, he pioneered several landmark procedures, including Nigeria's first selective renal angiogram and the first endovascular limb salvage revascularization procedure for critical limb ischemia and occluded arteries in patients with peripheral arterial disease. His groundbreaking work has also led to discovery and publication of several first ever interventional cardiology cases in Nigeria, including the first coronary cameral fistula case in Nigeria, as well as the first angiographically documented anomalous coronary artery case in Nigeria, amongst others. Professor Badero is currently a visiting professor of medicine at the University of Lagos and serves as CEO of Cardiac, Renal, and Vascular Associates in Jackson, Mississippi, USA. And so I finally come to the end and the beginning of this personable profile. You are very welcome to the stage, sir.
Thank you very much. Well, thank you, Dr. Hussaini, for that wonderful introduction. I want to thank everybody for being here. It's my pleasure to be here. I want to recognize all the distinguished people and all these wonderful faces, doctors, and all the people in attendance. So, you know, they say direction turns movement into progress. So what we're going to do here is basically help in the direction of what people already do. The movement that people are doing, we're going to turn it into progress. You know, motivation is a visitor, and discipline is a family. So we all have the motivation after all this wonderful speech by all the people that have spoken, the professors and all that. And we're going to turn it into discipline, which is what we do as a family. So, endovascular management of peripheral vascular disease. I'm going to just move through a couple of these things very quickly. What I want you to focus on is concepts. I'm going to speak contextually and conceptually. So you don't necessarily have to pay attention to the nuances, just follow the concepts and the other stuff will be okay, all right? All right, so this is the outline of what I'm going to talk about. I'm going to talk about the anatomy, the etiology, the epidemiology, and risk factors. We're going to touch on the diagnostic evaluation. Then we're going to talk about the treatment, which focuses on the medical therapy, endovascular treatment. I'm not going to talk about acute limb ischemia. I'm not going to talk about the surgical management because this is endovascular management. Before we start, I want you to watch this video. No volume? Is there a volume? no volume? All right, looks like we don't have any volume. But anyway, this will have been a very nice thing to watch. She's a friend of mine. She's one of the world-renowned actors in the U.S. And she formed a PAD coalition with the patients, and she's an advocate for PAD. And what she's saying here is that 85% of patients that were going to get amputation, nobody ever told them that they have peripheral vascular disease. And when they took those patients and they checked, they found out that 100% of them had peripheral vascular disease. So this is not just a problem in Nigeria, it's a problem everywhere. And I'm sure you guys have come across, there was something that happened on Facebook, that was posted on Facebook about a Nigerian who's in somewhere in Mississippi, Cleveland, Mississippi, who decreased the amputation rate by almost 90% when they go to, so this is really an epidemic. So let's move on real quick. So like somebody mentioned earlier, the concepts I want you to understand is PAD is not just a marker, it's a marker of myocardial infarction and ischemic stroke. So don't just look at it as something that affects the legs. Look at it just like Dr. Asongwa said, something that affects the heart. So you can see the ischemic stroke, coronary artery disease, PAD, but we're going to just focus on the PAD. But every time you're seeing a PAD patient, always make sure you risk evaluate or risk stratify them for myocardial disease, coronary artery disease, as well as ischemic stroke. So we're going to talk about the anatomy real quick, just to bring you back to, a brief touch on the anatomy. So everything starts, from the aorta that comes from the heart, right? And then when it gets to the pelvic area, it divides into iliac arteries. You have the common internal external iliac artery, and then you have the common femoral artery, which gives rise to the deep femoral and the superficial femoral. The other concept I want you to understand is that as the arteries come from the cranial to the caudal, they decrease in size. That's one concept I think you need to understand. As the arteries go from the cranial, from the head to the bottom, the size decreases. So it doesn't matter how much blood the heart is pumping with all these big arteries. If you cannot get to the foot, because you need the foot to move, if you cannot get to the foot, there's a problem, right? So your superficial femoral artery becomes the popliteal artery as it enters the adductor canal. There are 3 segments in endovascular medicine. We talk about the P1, the P2, and the P3 segment. And then you form it gives off the anterior tibial artery, which is the first branch that comes off. The anterior tibial artery comes from the back. It pierces the interosseous membrane, which is between the tibia and the fibula, enters the anterior compartment, goes all the way down. The importance of the anterior tibial artery is it forms a loop. So the anterior tibial artery eventually becomes the dorsalis pedis artery when it passes the interosseous membrane, okay? Now, once it becomes the dorsalis pedis, it gives off some branches. One of the important branches that it gives off is the arcuate artery. The arcuate artery, as you can see right there, the one that is kind of like horizontal, now anastomoses with the lateral tarsal artery, okay, and then forms that dorsal loop, which is very, very important to feed the limbs, the digits. Then the posterior tibial artery goes back, gives off some branches to the malleolar region. Then it gives off 2 branches, okay? The medial plantar and the lateral plantar. The medial plantar is a smaller version, the lateral plantar is bigger. That lateral plantar will now anastomose with the deep plantar branch of the anterior tibial artery to form the loop underneath, what we call the plantar loop. These become important in endovascular medicine, especially with ulcers and wound formation. And then you have the third artery, which is the peroneal artery. It ends in the calcaneal region. The importance of the peroneal arteries gives, nutrient arteries, some muscular arteries, but more importantly, it gives a communicating branch to the posterior tibial as well as a perforating branch to the anterior tibial. So it serves as a way to form collaterals anytime one of them is occluded. So this is what it looks like when you do a CT angiogram on MRI. So this is just the same the arterial findings. We divide them into 3 segments: the aortoiliac, the femoral popliteal, and the tibioperoneal. So from the pelvis to the knee, and from the knee to the foot. So how does atherogenesis start? So basically, your cholesterol, you have the good, the bad, and the ugly. The bad cholesterol is your LDL, right? The ugly one is the total cholesterol, and then the good one is the HDL. So the LDL goes in. So things like high blood pressure, diabetes, they make the vascular wall very sticky, very leaky, and very permeable. So the LDL becomes oxidized, right? Once it becomes oxidized due to an injury, it enters into the vascular system. There you have some monocytes that will kind of take it up and become what is called a foam cell. These foam cells now release inflammatory mediators like interleukin-1, TNF-alpha, monocyte chemoattractant particles, things like that. They will now trap it, cause inflammation of the smooth muscles, and then the plaque is formed. So this is the way atherogenesis starts. And the important thing is it starts from the age of 10. Actually, it starts from your first decade. It starts as fatty streak. From the fatty streak, it becomes intermediate lesion, and then it becomes an atheroma, usually in your third decade. So this thing already starts early. It's not like something that starts at 50 or 60. It's starting at a very early age. And then by the time you get to your fourth decade, then you have fibrous plaque, which may not become ruptured plaque. Again, we already talked about this. They make the endothelium becomes leaky, sticky, and unable to relax. So now you cannot have vasodilatation, you have vasoconstriction, and that's one of the problems with peripheral vascular disease. Now we're going to go straight into the prevalence. In the US, it's estimated to be like 8 to 12 million people live with peripheral vascular disease. There's no estimate in Nigeria, but I'm going to give you the estimate today. There's no estimate currently in Nigeria. So how do we come to the estimate? There are 242 million people in Nigeria right now. There was a study that was done by Oyelade and his colleagues that found that 3% of people in Nigeria are diabetics. And I'm sure Dr. Kido can attest to that. 3% of population in Nigeria are diabetics. So if you do the math, that's going to give you somewhere around 3.5 million. Okay? So 3% of people are diabetics. That's going to give you 7 million. Now, out of the diabetics, there's a study that shows 52% of diabetics have peripheral vascular disease. So half of 7 million is 3.5. Okay. There's another study. If you look at how much people are over 65 in Nigeria, it's 8 million people over 65. 40% of elderly patients in Nigeria have peripheral vascular disease. So do the math. Another 4 million, add that to 3 million or 4 million, you got 8 million Nigerians living with peripheral vascular disease, which is similar to what you have in the United States. So this is a lot. Now, this is a study by Oyelade and his colleagues, a very good study. They were looking at diabetic patients instead of peripheral vascular disease in our diabetic patients, and also the utility of ABIs in those patients. I'm going to point your attention to three things. One, 52% of patients that are diabetic will have peripheral vascular disease. Two, how many patients present with claudication? 24%. A quarter of them will present with claudication, which is the speakers of earlier have talked about this. So most of your patients are not going to present to you with intermittent claudication. So what that means is that most of the patients are going to see, they're asymptomatic. So you have to have an index of suspicion. If not, they're going to go unnoticed. Lastly, a lot of times we focus on feeling the pulse. And we say, oh, the pulse is present, so everything is okay. No. So the pulse is not even a good way to check because only 11% of patients had absent pulses. So most of these patients had present pulses, but that doesn't mean that they don't have peripheral vascular disease. So that's the key I want you to take from this slide. Somebody talked earlier, it increases with age, starting from the age of 50, and you can see from this chart, it goes all the way higher. So, and this is going to come to talk in regards to what patients you screen for. Polyvascular disease, like they mentioned before, 63% of patients that have peripheral vascular disease have other vascular disease in other beds. Now, out of those other beds, look at that. Coronary artery disease and peripheral vascular disease, 40%. So 40% of your patients with peripheral vascular disease are going to have coronary artery disease. That's what Dr. Asonga was alluding to earlier, talking about. So when you see your patients with peripheral vascular disease, don't stop at looking at the legs. You need to re-stratify the heart because that's what's going to kill them, not the peripheral vascular disease, is a coronary artery disease. That's why these patients need to be referred to cardiologists and interventional cardiologists because we can re-stratify both of them. We talked about internal risk factors. The most independent risk factor is diabetes, okay? And you can see smoking and cholesterol. And all these risk factors are synergistic. What do I mean by synergistic? I'm going to show you in a bit. This is a very important slide. This is a slide that shows that 30% of the patients that you see in a primary care, this is why primary care doctors are very, very important. Like the wonderful family care doctor that, was here earlier. You need to screen those patients because these are studies that have been done, NHN study, Henihan study, and then the Partners trial, which show that in patients over 70 or patients that are 50 with diabetes, 30% of them have peripheral vascular disease. So what does that mean? Those patients I see at the Idejo, a third of them are going to have peripheral vascular disease in Idejo clinic or other clinics that you have around. Remember that a third of your patients in primary care clinic have peripheral vascular disease. That tells you that you need to screen them. This is what I meant about the synergistic effects. As the higher the systolic blood pressure goes, and patient that is a smoker, or you have your cholesterol is higher, all these things come together to increase the risk of peripheral vascular disease. So they don't act alone. They act in pairs like terrorists. Terrorists don't act alone. Most of the time, they act together. I see people are laughing there, But it's the truth, right? So they don't act alone. They act together. So somebody has a smoker that, blood pressure is high, is uncontrolled, the cholesterol is high, they're eating a lot of puff and all these things. So no shades. No shades. So synergistic. I noticed that Professor Omefoka, he didn't touch his own puff yet. Anyway, why should you care about PAD? Okay, as a primary care doctor, why do you care? Why should you care about PAD? 1, is very common as we know. 2, is equivalent to high cardiovascular risk. 3, is progressive. 4, it's silent but not benign. Even though it is silent, it's not benign. It's under-recognized, under-diagnosed, under-treated. It can save life and limbs. It can be readily diagnosed in primary care, like the wonderful patients mentioned that, your primary care doctor, they're close to them. They want them to continue to be part of the care. So it can be diagnosed in the primary care doctor, in the endocrinologist's office, or even in the cardiologist's office. And primary care doctors play a very, very key role in the management, as other medical professionals. All right, so I'm not going to spend too much time here. We've talked about the clinical manifestation. All you need to know is most of them are asymptomatic, okay? So remember, you have to examine them. You have to talk to the patients. Most of them don't have any symptoms. Those that do have intermittent claudication, and from there it's going to progress to rest pain. Intermittent claudication just means they work a little bit, and then they have pain, they have to rest, and then they progress to rest pain, which usually occurs at night, which can be misdiagnosed for neuropathy, which also happens at night. Okay, we've talked about this. All right, I think Dr. Kerodolu touched on this. So with patients that have intermittent claudication, there are two classifications, the Fontan and the Rutherford. The Rutherford is more popular. It's very easier to remember. It's from 0 to 6. 0, 1, 2, 3, just the claudication, mild, moderate, and severe. 4 is rest pain. 5 is minor tissue loss. 6 is major ulceration and gangrene. But 4, 5, and 6, we refer to them as critical limb ischemia, or the new terminology is critical limb-threatening ischemia. Those patients, you have to take care of them right away. They're equivalent to patients in the coronaries, like Dr. Mario Kodomi knows, that have acute coronary syndrome. All right, so this is very important. It's the tip of the iceberg. I want you to focus on one thing. In a patient that is over 55, 5% of them will have intermittent claudication. Remember, we said most of them present with no symptoms. No symptoms. So the ones that have intermittent claudication, you have to look at them from 2 dichotomous variables. You have to look at them from the limb problems and the cardiovascular problems, okay? Not just from the leg. Now, what happens in those patients that have intermittent claudication? In 5 years, a third of them are dead. In 5 years, a third of them are dead. And in 20% of them in 5 years will have a stroke. So half of them will either be dead or have disabling ischemic stroke. Half of them in 5 years. Now, what happens? That's the cardiovascular outcomes. What happens to the peripheral vascular outcomes? 5% of them will have major amputation. and 16% will have worsening condition and claudication, and 7% will have bypass surgery. So basically, if you add all that together, it's almost like a third of them, their limbs will get worse. So the context, the concept I want you to understand is a third of them, the limbs will get worse or amputated. Half of them will either be dead in 5 years or have ischemic stroke. A third of them, the legs will either be cut off or have worsening conditions or require bypass surgery. And half of them will either be dead in 5 years or have major ischemic stroke. Now, look at this slide. It's very important. What is the importance of PAD on mortality? In 10 years, even those that have no symptoms, half of them are dead. Look at that, okay? So in 10 years, you can see there's asymptomatic, there's ones with symptoms, the ones with severe symptoms. Even those that have no symptoms, if you follow them in 10 years, half of them are dead in patients with peripheral vascular disease. All right, so we know they are 6 times at risk of having death from cardiovascular mortality and 4 times the risk of a fatal MI. Any patient with peripheral vascular disease has a 4 times the risk of a fatal MI or dying, 6 times the risk of dying. Now, this is very important for those that are doing interventional work. In PAD patients, they have risk, what we call peri-procedural risk. So when you take a PAD patient to go do a cath, they have an increased higher risk of having issues like MI, stroke, when they get a PCI or when they get a bypass surgery. So even the surgeons, like my good friend, Professor Ogunleye, he knows that when you take these patients to do an open heart surgery, you have to bear in mind that the patients with peripheral vascular disease are at risk of having peri-procedural complications. Now look at this 5-year mortality in patients with peripheral vascular disease. Whether you have no symptoms or you have symptoms, 14% of them are dead in 5 years. 14% of patients with either no symptoms or with symptoms of peripheral vascular disease are dead in 5 years. That 14%, I want you to keep that number in your mind. I'm going to show you what happens in the next slide. All right. What now happens to those patients that have acute MI and present to Dr. Majikudumi, for example? They have an acute MI. Now, a patient that comes in acute MI that has peripheral vascular disease, in 360 days, in 1 year, 14% of them are dead. So what does that mean? It means that even if they present with an acute MI, the fact that they have peripheral vascular disease is an independent risk factor that you need to be sure of. So when you're taking care of those patients that show up in your hospital with acute MI, and you know they have peripheral vascular disease, you have to be very, very careful because, as you can see in this Kaplan-Meier curve, 14% of them are dead. And that's a very significant p-value. All right, so we're going to peel away the curtains. We're going to get inside the room and examine your patients. So what you need to do, we've already talked about all this. You got to examine them from head to toe. Check their legs, check their arms. If there's a differential blood pressure of 15 millimeters of mercury, that is suggestive of subclavian stenosis. Take off the socks. We always say take the socks off, take the socks off, take the socks off. Examine their legs, check the pulses. These are the ways we identify the pulse. 0 is absent, 3 is bounding, and that's how you record it. And this is what it looks like. The first one on top, this is what we call elevated pallor. So this is critical limb ischemia. When you raise up the leg, the color disappears. At night, they have to dangle their feet because the blood has to be dependent and has to come down. This is what we call dependent rubor. You can see the leg is reddish when they dangle it. When they lift it up, it becomes pale. And then the next thing you start seeing is minor tissue ulceration, and then it leads to frank gangrene. The non-invasive assessments, I'm going to go real quick. So I put them side by side. Coronary artery disease and peripheral vascular disease, they're very, very similar. In coronary artery disease, we do EKG, echoes, stress tests, and angiography. In peripheral vascular disease, your ABI is akin to your EKG, and the echoes akin to your Doppler study. And then the stress test, you can also do a treadmill stress test in this patient. In fact, you should do it, and I'm going to tell you in what areas that you do that. And your angiography is your CTA, your MRA, or your digital subarachnoid angiography. All right, we've talked about the ankle-brachial index, how important it is. It's 95% sensitive. These are the numbers here. The normal is greater than 0.90, And if it's greater than 1.4, it means the artery is non-compressible. And I'll tell you the importance of that in a minute. This is how you measure the ankle brachial index. The higher blood pressure in the DP or the PT. So the DP is anterior tibial artery, the posterior tibial artery. You measure both of them. You look at the one that has a higher blood pressure, and you put it against the higher brachial pressure, either the left or the right. So for this patient that has blood pressure in both arms, the one on the right arm is higher, it's 120, okay? And on the right leg, you can see the posterior tibial artery is 68, the dorsalis is 64. So the ABI on the right will be 68 over 120 on the right. And on the left, it's going to be 136 over 120. That's how you measure the ABI. This is a study that we published over 20-something years ago now, looking at ABI as a predictor of 3-vessel disease and left main coronary artery disease in African-American patients. And guess what? There was a 85% sensitivity with an abnormal ABI of less than 0.90, which was predictive of patients with left main and triple vessel disease. Imagine that. ABI as a screening tool, you can use it to predict who is going to have triple vessel disease, multi-vessel coronary artery disease, or important left main coronary artery disease with a very, very high sensitivity. In medicine, 85% is pretty good. All right, so this is ACC guidelines. Somebody asked in the audience earlier, what kind of patients do you screen? Anyone that has exertional leg symptoms, you need to screen with an ABI. Anyone who's over 65, you need to screen with an ABI. Anyone who's between the age of 50 to 64 and has any risk factors, diabetes, high cholesterol, you need to screen. Anyone that is less than 50 years old, this is very, very important, less than 50. So even if the patient is 40 years old and she's diabetic and has another additional risk factor, then you need to screen them. So it's not just patients that are above 50 or above 65. If the patient is 40, has diabetes, and has another additional risk factor, you have to screen with an ABI. And this is pulse volume recording. That's another way to check. These are some of the non-invasive testing, and this is what a normal one looks like. You see the dichrotic notch. Mildly abnormal, the dichrotic notch disappears, and moderately abnormal, you can see the waveform is lower, and then in severe abnormality, it's almost like a flat line. Sometimes you have to do stress testing, like I mentioned. So, for example, if a patient has typical leg symptoms and then you do an ABI, and the ABI is normal, the next question is, what do? You stress the patient. In this patient, the ABI was 0.68. You stressed her, and she went to 0.37. Look at the left leg, it was 0.95, which is a normal ABI. When that patient was stressed, ABI went down to 0.60. So you have to stress this patient if you think that if your pretest probability, what we call the Bayes theorem, if your pretest probability is high in those patients, and even if the ABI is normal, don't stop there. You need to exercise those patients because you're going to be missing a lot of the patients. Duplex ultrasound, we all know what that is. So this is what a duplex ultrasound should look like. This is what we call a laminar flow. Okay, laminar flow, there's no obstruction, as opposed to this one that has mosaic flow. You can see the mosaic flow. And this is the peak systolic velocity. Anything less than 150 is normal. Between 150 and 200 tells you the stenosis is around 30 to 40%. Between 200 and 40 tells you the stenosis is between 50 to 79%. Anything above 240, like in this patient, means it's over 75% stenosis. That's how you interpret an arterial Doppler study. So transcutaneous oximetry, a lot of surgeons, I know they like to use it in terms of determining whether the wound is going to heal. It should be between 60 millimeters of mercury. Anything that is less than 25 tells you the wound is not going to heal. So they do it a lot in the United States. I'm sure they do it here too. You have a patient that has a wound, you just put some electrodes on and check the oxygen level. And if that, if the TCO is less than 25, you already know that wound is not going to heal. And if it's around 60, at least you're confident that the wound is going to heal. Okay, so this is an algorithm by the American College of Cardiology. This is what you do when you see a patient that you suspect PAD. What I want you to focus on, because it's a busy slide, the patient has a history that is suggestive. They say if he walks like a dog, quacks like a dog, is most likely a dog, right? So if that patient has symptoms, the first thing you do is an ABI. Now, if the ABI is non-compressible, like 1.4, do you stop? No, you don't. You do what is called a toe brachial index. And if it is greater than 0.7, you stop. That patient doesn't have peripheral vascular disease. If the toe brachial index is less than 0.7, then you go to the same algorithm. You know, you can tell them to do exercise therapy, and then it doesn't resolve. Then you do, you know, CTA, angiography, arterial Doppler, things like that. Any patient that is, the ABI is less than 0.9, you go the same practical route. And in those patients that have normal ABI, like we mentioned, you stress them. So if the ABI is abnormal, you go through the, you know, the Doppler studies. If the ABI is normal, you stress them. If the ABI is hypernormal, then you do a toe brachial index. So this is the algorithm that you need to know in your mind. This is what a CTA looks like. There are some limitations to CTA. I know some people like to do CT angiogram. Some of the limitations include heavy arterial calcification. So those patients that have CKD have arterial calcifications, because calcifications in CKD patients start at 3B. Stage 3B is when you start having coronary calcifications, even without symptoms, in patients with chronic kidney disease. So those patients usually have heavy arterial calcification. Those are the ones that you're going to have non-compressible ABI. And CTA might miss or underestimate the stenosis. Some of those patients that have CKD with eGFR of less than 30, radiologists are very skeptical. They don't want to do CT angiogram in those patients, because when you do CT angiogram, you're going to use close to 100 cc's of dye. And, you know, they're not going to pre-treat some of these patients, you know, because they're not the doctor taking care of the patient. So they might be very skeptical doing a CT angiogram in those kind of patients. And then some of the patients that have EF, low EF, heart failure patients, low EF, very poor forward flow, this kind of sometimes runs too fast, that it doesn't catch up with the blood as it's coming down. So they can always adjust that, but those are some of the limitations. And then the sensitivity of a CTA is lower below the knee. The sensitivity is around 80 to 90%, but below the knee is around 81%. So it might not be very good for small vessels, especially your infrainguinal, infrapopliteal vessels. And then you can do an MR angiography. This is what a normal MR angiography looks like. One of the problems with MR angiography is that some of these patients, like I mentioned, they have the same risk factors as coronary artery disease. So some of the patients have chronic kidney disease. You do not want to do an MRI with gadolinium in patients with chronic kidney disease. Why? They can have what we call nephrogenic systemic fibrosis, NSF, and there's no treatment for that. You can do sodium thiocyanate and all these things, but really it doesn't work. So people are very skeptical. I know radiologists, if you know the patient has CKD, they're not going to want to do MR with gadolinium products because of that risk of NSF. And this is what a normal abnormal MR angiogram looks like. You can see the bilateral SFA with the CTO. And this is what a normal digital subtracted angiography or invasive angiography looks like. You can see there's a CTO on the left SFA. All right, so I'm going to move quickly to the therapies because of time. The therapies are divided into three. One is the cardiovascular preventive therapy. So those patients need to be put on antiplatelets, statins, because statins do a lot of things. They stabilize the plaque, and then they prevent inflammation, okay? And then you want to give ACE inhibitors like Dr. Akeredolu mentioned earlier. You want to reduce the symptoms by doing exercise. You have to give cilostazol. I'm going to show you a study recently that supports cilostazol. Endovascular interventions reduce symptoms. Surgery reduces symptoms as well. But when it comes to saving limbs, there are only two therapies. It's either endovascular revascularization or surgical revascularization. So if you're going to save limbs, only two therapies, endovascular revascularization that we're talking about or surgical revascularization. If you want to reduce symptoms in a claudican, the patient has claudication, you can do exercise, you can give cilostazol. If it doesn't work, then you can now move to endovascular intervention or surgery. While you're taking care of reducing symptoms or saving limbs, you also have to take care of preventing death, MI, and stroke, and putting these patients on antiplatelets, statins, and ACE inhibitors. It's not enough for you to fix the leg and restore blood flow and not put that patient on antiplatelets or statins or ACE inhibitors. That patient can still have an MI. So it's a class 1 indication in American College of Cardiology to give cilostazol, 100 milligrams twice a day. You cannot give this in patients that have CHF. So the contraindication to cilostazol is CHF, but it's a class 1 indication to give cilostazol in your claudicants. If you're trying to tell them to exercise, you don't want to do endovascular revascularization, you have to give cilostazol. And this is the reason why this was a study that shows when they compare cilostazol to pentoxifylline. Back in the days when we were doing all this pentoxifylline, that was what we were using initially, but there was a head-to-head comparison with cilostazol that showed that cilostazol gives you more improvement in walking distance and things like that. And that's why cilostazol is the one that's been only drug that's been shown to improve walking distance. So you don't use methoxyphylline anymore, but remember, don't give it to patients with CHF. Okay, we talked about this. So what I just want you to remember here is critical limb ischemia. Remember the Rutherford stage 4, 5, 6 is akin to acute coronary syndrome. So when you see somebody that has an ABI of like 0.4, that's Rutherford stage 4. They have rest pain. They're having pain all the time. The pain starts with when they walk, they have the pain, they rest, pain goes away. And it tells you, doc, the pain always comes now. Even at night, I have to dangle my leg. That is ischemic rest pain. That is critical limb-threatening ischemia. That patient, what you're trying to do is to salvage that limb. This is not about improving symptoms. Because you're going to hear people say, well, go and walk and then your symptoms are going to get better. No. If the patient has rest pain, this is not a time to improve symptoms. You need to save that leg because it's like a patient having acute coronary syndrome that prevents you with a chest pain, troponin is elevated. You have to go in and fix the heart. Now, if the patient has claudication, that is akin to angina, either stable angina, chronic stable angina, things like that. You can give them, you can still buy it with some time. But I'm going to talk about in Nigeria and the developing countries. A lot of these recommendations are done in the developed countries. We're not in a developed country. The difference with the developed countries is patients see their doctors regularly. The insurances pay for these treatments. They don't pay out of pocket. The patients are aware of these things. We don't have the myths, the mysteries, and the realities that come with living in developed countries. Some of us, your family member will tell you, don't worry, we're going to pray about it. I'm not saying don't pray about it, things like that. But we have people that are supposed to get procedures and somebody talks to them and say there's a way, we had a doctor that was talking about, people going to traditional birth attendants instead of going to the doctors and things like that. So when you have this kind of patients in the developing countries, sometimes you cannot wait because when you wait, that patient is not going to come back to you. The next time you see that patient is an ulcer and it's too late and then you have to cut off the leg. So this is AACC guidelines in terms of how do you manage this patient. So let me just give you a brief overview. Class 1 indications are things you have to do. Ultimately, you have to do it, absolutely. Class 2 indications, 2A indications are things that you should do because the benefits outweigh the risk. Class 2B indications are things that you may do. Class 3 indications, things that you don't do. So anytime you see in literature in the United States, you're going to see class 1, class 2, or class 3. Class 1 you have to do. Class 3 you don't have to do. That's all you need to remember, class 1 and 3. What you do, and what you don't do. So this is a class 1 indication. So it says endovascular procedures are indicated for individuals with a lifestyle limiting claudication. Lifestyle limiting. So if you have a patient who has a claudication and the claudication is limiting his lifestyle, these patients need to get endovascular revascularization. So what I'm trying to tell you is that endovascular revascularization is not only for patients with rest pain or critical limb ischemia. If that patient tells you every time I walk, I have pain, it's affecting my lifestyle, you need to do something about it because it's a class 1 indication. I'm not going to spend too much time here. This is the Transatlantic Interconsensus Society. They've divided some of these lesions into a task A, B, C, D. All you need to know is that A, B, and C are good for endovascular management. Task D, which are the diffuse lung lesions, traditionally can go to the surgeons. But now endovascular management has improved a lot that we can still take care of that task D patients. But traditionally, those patients benefit from surgical management, and I'll tell you the caveats to that. I'm just going to talk really briefly about open surgical versus endovascular. Again, this is not a talk to compare one to the other, But some of these patients are surgical patients, like I mentioned earlier. Some of them can benefit from endovascular management. Now, the thing I want you to know here is that with the endovascular revascularization therapies, we are approaching what is called an equipoise. So you have 90% success rate, and we now have up to 80% patency, primary patency rates. The same thing you're going to get in a surgical patient where the surgeon uses a vein graft. Very key, a vein graft. So if a surgeon uses the vein graft to do a bypass surgery, you're going to have 75% primary patency rate. If they use something else that is not a vein graft, the patency rate goes very, very, very low. And then remember, here's the only difference is that with surgery, you have 1 to 3% mortality, which you don't have in endovascular management. One of the differences. All right, so the common femoral artery is a place for the surgeons. We don't like to stent the common femoral artery. Traditionally, we don't. I had a patient a couple of weeks ago that had 100% CFA disease that could have stented. But I sent the patient to a vascular surgeon, and he got endarterectomy with peak pericardium. So the common femoral artery, we typically don't send. If you have a patient with a heart, something like that, we send to the surgeon. But I'm just showing you this to show you that there's a new study that was done 7 years ago, I think now, or 9 years ago, that compared stenting to surgery in the common femoral artery, and no difference. No difference in both of them. Okay? So I'm sure at some point they're going to come up with some scaffolds that people can use even in the common femoral artery. But for now, if you have a patient with a common femoral artery stenosis, that is 100% occluded, send that patient to surgery. If it is like 60, 70% blockage, you can use balloon angioplasty to open it. Or I'm going to show you later on, I've had a patient like that that did atherectomy, and she did fine. So we're going to move straight on to the femoral popliteal area. The difference with the femoral superficial artery is that it is prone to abuse a lot, okay? Torsion, extension, just because of the location, we move our thighs a lot, play football and all these things. So it moves and is prone to a lot of distortion. And that's why a lot of your disease are going to be in the SFA, which is the superficial femoral artery. And we've talked about the patency rate again, 85% in 1 year with endovascular technique. With surgery, they can do that, 1 to 3% mortality. So it's basically, which patient will benefit from what. This is what I was trying to tell you. So in 5-year patency rate, if you use an autologous vein graft to do a bypass, it approaches 74 to 76%. But if you use a PTFE graft, the patency is less than 75%. So averagely around 40%. So what does that mean? Like that patient that had peripheral vascular disease, that had triple vessel disease, they must have used the 2 vein grafts to bypass the coronaries. So that means the patient doesn't have any vein graft, right? So if that patient needed a bypass on the legs and they use a PTFE graft, in 1 year, 40% patency, 60% is gone. So anytime the surgeon wants to do, like if you're going to repair a patient to surgery for bypass, if that patient has already had a coronary artery bypass and they've used the vein grafts, you may want to do endovascular management in that patient, because if that patient gets a bypass graft, 60% patency rate will be gone in 5 years. This graph just tells you that SFA stenting is superior to balloon angioplasty. Traditionally, we started with balloon angioplasty, but now we're putting stents. This is the reason why we put stents, because the restenosis rate, as you can see here, is cut into half just with the stent compared to balloon angioplasty. But there's a caveat now. We try not to use scaffolds anymore. We try not to leave the stent behind. So what we do is we use atherectomy devices to shave off the calcium with balloon angioplasty, and you get excellent results. Or you can do atherectomy with drug-coated balloon. I'm going to show you some of the studies for that. And this is what a balloon, the types of stents you have. You have balloon expandable stents, which a lot of times we use in the iliac areas, and then the self-expanding stents. They can still be used in the iliac areas, but most of the time we use in the SFA. So this is a study. There are 2 studies here that compared drug-coated balloon in SFA. There's the IMPACT study. They used 331 patients. It was a single blinded study that was done. They used paclitaxel-coated balloon, and you can see the primary patency rate was 82% compared to just a regular balloon angioplasty. This is where we started moving towards drug-coated balloons because it gives you more patency rate compared to just a regular balloon. Now, the Thunder trial was done some years ago, looked at, I think it was like 154 patients, paclitaxel-coated balloons, and you can see survival was better in those patients that just used the drug-coated balloon compared to regular balloon. So these two studies were the landmark studies that showed that drug-coated balloons now the way to go. A lot of people use drug-coated balloons as opposed to just regular balloon angioplasty. This drug-eluting stents, this is just comparing the Ziva stents. So we've moved from drug-coated balloons to drug-coated stents. And the Ziva stent was one of the trials that was used and shows that with Ziva stents you have better patency rate compared to just a regular nitinol stent or self-expanding stent. Okay, I talked about atherectomy. We don't have that in Nigeria. Right now I do this a lot in the US, and hopefully one day we'll be able to get the reps to bring the, I mean, I do have some of the consumables, we just don't have the, what we call the console. So you have directional atherectomy, you have orbital atherectomy from CSI, you have excisional atherectomy, and we have laser atherectomy. The laser atherectomy are good for CTOs that are, you know, more with thrombus. But if it's very, very calcified, you don't want to use laser atherectomy, you want to use orbital atherectomy, and it does what we call differential sanding. So it sands around the calcium, modifies the calcium so that you can now use your balloon. And we also have intravascular lithotripsy, which we use in the coronaries as well as in the legs as well. And this is the study that proves that, definitive early study. You can see primary patency rate in 12 months, 82% with using atherectomy. So we have a lot of armamentarium in endovascular revascularization, drug-coated balloon, drug-coated stents, as well as atherectomy devices. All right, so this is a summary. Remember, vein bypass grafting, 75% patency in 5 years. PTFE graft, 40%. So this is put everything together, okay? Stents, 70% patency rate. Drug-eluting stents, 75% patency rate. So equivalent to you doing a bypass with a vein graft. Atherectomy is a winner, 80% patency rates. This is why we try to use atherectomy a lot, and we don't try to use as much stents if possible. All right, so this just tells you the higher the more complex the lesion, you may want to go for surgery, less complex endovascular, but it's a changing paradigm. So after you've done all your great intervention, we've talked about the medical therapy, we've talked about endovascular vascularization. Now, we don't just use aspirin and platelet and clopidogrel anymore. We use rivaroxaban, 2.5 milligrams twice a day with aspirin, and I'm going to show you the study that backs that up. If you have to give clopidogrel for those patients, you stop it in 30 days. Now, the difference is if a patient comes in with coronary artery disease or an MI and you have to put a stent in the coronaries, and that patient is already getting, like, you know, has atrial fibrillation, is already getting an anticoagulation. So what you do is you give the triple therapy, usually for less than 4 weeks, usually the duration of the hospitalization, and then you stop the aspirin and continue the clopidogrel and the anticoagulation. That's in the coronaries because there's a study for that. But in the peripherals, you use rivaroxaban and aspirin, you stop the clopidogrel. There's no point for the patient to be on clopidogrel. And you check that patient in 1, 6, and 12 months with ABI and aggressive follow-up. This is a Voyager study, looked at over 7,000 patients, was published in the New England Journal of Medicine, so it's a big study. And they randomized patients that had lower extremity revascularization procedures to rivaroxaban and aspirin, and just to aspirin alone. And you can see here, you can see in the conclusion, there was a major reduction in MACE in those patients that had rivaroxaban and aspirin. This is why you now use rivaroxaban and aspirin. This next study is the COMPASS study. In this COMPASS study, they looked at all comers, patients that had MI, cabbage, 40 days, a long time ago. They randomized them into 3, 2.5 milligrams twice a day of rivaroxaban with aspirin, or 5 milligrams of rivaroxaban by itself, or aspirin by itself. And you can see here, patients that got rivaroxaban and aspirin did better, 2.5 milligrams. And this actually study was stopped abruptly because of the improvement in major adverse events we're talking about ischemic stroke, cardiovascular death, mortality was much better, so they had to stop the study. So this is what cemented rivaroxaban in patients, because the advantage is not just in your limb effect, it's also in your cardiac effect as well. And this is a sub-analysis of that COMPASS trial. COMPASS trials. So in this sub-analysis, they check patients that are already on clopidogrel, okay? And then they give them the rivaroxaban and aspirin. And those on the right without clopidogrel, they give them rivaroxaban and aspirin. The difference was still there, right? You still had big changes and big improvements in those patients, which tells you they don't need to be on clopidogrel, right? Because you can see in the right side of the graph, those patients did not have clopidogrel and they still showed a benefit. All right, so this is a principle of intervention. You want to improve the inflow first. So if you have a patient that has an iliac occlusion as well as an SFA or something below the knee, you want to treat the inflow first, okay? Increase blood flow to that area. The symptoms still persist, then you can go down and improve the outflow. So the key is to improve the inflow first before you improve the outflow. But if the patient has what we call a chronic limb ischemia, critical limb ischemia, the teaching is you want to fix straight line. You want to restore straight line flow to the leg. Straight line flow all the way to the foot because it's critical limb ischemia. All right, so this is the last part of the talk. So critical limb ischemia, one of the concepts Professor Mfuwaya was talking about, wound healing. You need 6 times the blood flow to promote ulcer healing in any wound. 6 times the blood flow. So if that patient already has peripheral vascular disease, you cannot get 6 times the blood flow to improve the healing because you have a lot of inflammation that's going on in wounds and infection and things like that. So if you cannot get blood flow there and all your antibiotics that you're giving in systemic antibiotics, if the blood cannot get to the point, the antibiotics is not going to get there to fix the problem. So that's one concept that you need to know. Again, we talked about the inline flow to the foot. Treatment of inflow stenosis is not enough when you have a patient with ischemic rest pain, ulcer, gangrene, tissue loss. You have to fix everything going toward the foot, not just one thing. So that concept of fixing inflow is only for patients with claudication. When it gets to rest pain or ischemic critical limb ischemia, you have to fix everything. All right. Remember this, something similar to this in claudication. We talked about 5% of patients over 55 will have claudication, right? And 30% will have mortality in 5 years. This is critical limb ischemia, okay? This mortality in 1 year, not 5 years. A quarter of those patients will be dead in 1 year. Remember, in claudication is 5 years. This is 1 year. 30% of them will have amputation. So anytime you see a patient with critical limb ischemia, don't send them home. You have to revascularize them, because if you don't, a third of them will have amputation, a quarter of them will be dead, and only 45% of them will be alive with 2 limbs. And even those that have alive within 2 limbs, 20% of them will have worsening critical limb ischemia and will die. This is a very, very important slide. The relative 5-year mortality rates, look at that. Critical limb ischemia, 67% in 5 years mortality. Higher than colorectal cancer, higher than stroke, higher than breast cancer, higher than prostate cancer. So I think it's a moment of thinking for us that in 5 years, these patients that have PAD and critical limb ischemia, 67% of them will die. Relative mortality, it is higher than prostate, colorectal cancer, ischemic stroke. So this is a very huge problem. All right. The tragic rule of 50s. Do you know what it is? 50% of untreated critical limb ischemia will have amputation in less than 1 year. Any patient that has critical limb ischemia, if you don't fix it, 50% of them will have amputation in less than a year. 50% of amputees will be above the knee or below the knee, not transmetatarsal, above the knee or below the knee. 50% of amputees will regain full mobility, so half of them will not even be able to move. And you know what happens when they can't move? They cannot contribute to the economy. They can't generate money for their families. They can't be productive, financially. That's the problem. So it not just affects them; it affects the whole family. And 50% of patients would die in less than 5 years. So it's a very, very important slide. 50% would die in less than 5 years, 50% will have amputation in less than a year, 50% of them will only regain mobility. And guess what? I think it was Prof that was talking about when they have amputation in one leg, sooner or later they're going to have amputation in the next leg. 50% of them will have second amputation in less than 5 years. So the moment the patient has gotten an amputation, you know within the next 5 years he's going to have a second amputation, because these diseases, they occur in pairs. So if you see somebody with a right anterior tibial artery stenosis, most likely they're going to have the same thing in the leg. So this is a case that we did at it was a Lagoon hospital that we published. This patient had a CTO, complete total occlusion of the SFA, that we got open and we published. And this is what it looks like. You can see on the left slide, the superficial femoral artery was completely occluded, and we're able to use some specialized catheters and wires that I brought from the United States, and we're able to get him open. And over there you can see the the popliteal artery was also occluded, was blocked, and we did just regular balloon arterioplasty, and this patient did extremely well. And he didn't have to go to surgery and went home the next day. Now, this is a very, very important concept. And the reason why I bring this up is because I've seen just some practitioners and, don't focus too much on this. This is what we call angiosome-directed therapy. Remember, we talked about inline flow, but there's a study that shows that even the angiosome-directed therapy improves the life of the patient. So what that means is, you can see right here, this is the territory of the anterior tibial artery. It supplies most of the dorsum of the foot. The posterior tibial artery supplies most of the plantar surface of the foot. The peroneal artery, which is the third one, supplies around the lateral malleolar region. What that means is that if you have a patient that has an ulcer in the dorsum of the foot, and that patient has anterior tibial artery blockage as well as posterior tibial artery blockage, you go after the anterior tibial. There's no point going after the posterior tibial, because where the ulcer is situated is in the angiosome of the anterior tibial artery. So you want to revascularize that anterior tibial artery and improve blood flow to that area where the ulcer is. So you want to get the best bang for your money. So if you see a patient that has a CTO of the anterior tibial artery, even if the patient does not have an ulcer yet and is having lifestyle-limiting claudication, you need to fix that anterior tibial artery, because if you don't, you're only relying on collaterals from the peroneal artery or the posterior tibial artery. Remember I talked about the arch. That arch, the integrity of that arch is gone because there's no dorsalis pedis. The dorsalis pedis might be a collateralization from the fibular artery or the peroneal artery, which is very, very small. And so if that patient comes back to you with an ulcer, it's too late because the ulcer may not heal. This is the study that shows the angiosome-targeted lower limb revascularization for ischemic foot wounds. It's a systematic review, and you can see the conclusion. The results show that when direct revascularization of the foot angiogram affected ischemic shows improved wound healing when you do angiosome-directed revascularization. So now you have two concepts: straight line revascularization of the foot, as well as angiosomes. I want you to remember that, and especially in patients that have wounds. Find out where the wound is located, do the angiogram, find out the blockage to the artery that is responsible for that area. That is the artery you need to go after first and make sure you revascularize. And if you can't, then you revascularize the other one, because it's still going to provide some kind of collateral and the arch, which is very important. Remember, there are two arches in the foot that are provided by both the anterior tibial and the posterior tibial. So if you can have both of them, it is good. If one of them is down, that arch, the integrity of the arch is lost. All right, so this is, I think, one of the last slides. What are the principles of revascularization? Claudicants should be revascularized after a trial of exercise therapy. Patient has claudication, do exercise therapy, do some medical management. If there's no improvement, revascularize. The only exception is if the patient has a lifestyle-limiting claudication. You have to revascularize that patient. Inflow and outflow should always be assessed. In the claudicants, improve the inflow first. In the critical limb ischemia, you got to fix everything. And remember the angiosome-directed revascularization as well. All right. This is something that is new that we've done. I've done a case. It's called percutaneous transmural arterial bypass. So it's like a surgeon doing a bypass without cutting the patient open. So I'm going to play this so we see what it shows, and I'm going to explain to you what is involved. I hope it plays. Oof, it's not playing? Okay. There's no audio? Okay. There's no audio. Anyway, I guess we'll just have to do it watching and see what it does. Okay. Good. The media team, is there any audio? Can you let it play? What you do is you access the tibial, the dorsal pedis vein or the tibial vein, and you come up with a snare, okay? And then you come on top through the artery that is blocked. You use that thing is called an endocross device, and you cause some kind of fistula or an osmosis between the artery and the vein, and then you bring down the wire all the way down. You snare it down, okay? And you're going to pass the blockage. You're going to see what happens as you bring the wire down in a minute. So once you get to the end of the blockage, usually around the popliteal or the distal SFA, there's a needle that you press. It will now go back from the vein inside the artery, and then you use the wire. So now you've bypassed the whole blockage going through the veins, and then you bring the wire down, and then you perform balloon angioplasty of both places, and then you put the covered stents. It's called the torus stent. Very high radial compression. And then you stent, make sure there's a 60 millimeter overlap, and then you bring it back into the proximal SFA, and then you have blood flow going from the proximal SFA into the vein, bypasses and goes back into the artery, and then you have your bypass without cutting the patient open. And there are studies and you can see that was the first case was done. You can see the knob to the SFA, and this is where it reconstitutes in the adductor canal. And you can see after we did the P-tab how the patient looks. Didn't have to go to the surgeon. And these are for patients where you cannot, go intraluminally or do reverse dissection or things that we normally do, and you can't go antegrade to basically open up the legs, and the patient is not a candidate for surgery. You can do this, for those patients. And these are studies. The study that was done is called a DETOR trial, and it shows the primary patient rate, the freedom for MACE, very, very high in those patients. Target lesion revascularization, very, very, very minimal for those patients. So it's backed by literature. All right, so in summary, And thank you for staying so far. I know there's a lot of slides. This is like 100 slides, but I'm almost done. So PAD can be regularly diagnosed in the primary care setting with the family practice doctors and the endocrinologists. Remember, patients at risk greater than 70 years old, lifestyle smokers greater than 50, diabetes. Symptoms, it's over here. Poor awareness, this is why we're having this. And this is not just to talk to the patients and the doctors, we're also reaching out to the insurance people. I hope that some of them in the audience, we can't do this without the insurance people, because this is the difference between Nigeria and in the developed countries. Developed countries, most people are insured, and it doesn't take time really to get authorization for these procedures, because there's something we call peer review. Anytime you call an insurance person and you say, this patient needs this, they ask you for your notes, they read the note, it's over there. If they have a question, the person that talks to you is a cardiologist, an interventional cardiologist or a cardiologist. So you can have what is called a peer-to-peer evaluation. When you talk to somebody who's not an interventional cardiologist, they may not understand what you're trying to do. So in America, you can't talk to somebody who's not, because for example, if a patient needs surgery, you can't be talking to somebody who's not a surgeon, because I might not understand what the patient needs. So what we are imploring, or we are asking some of these insurance people, is when the doctor tells you that the patient requires something, you take it seriously, because, we're all doctors here, and I know we all swear an Hippocratic oath. We're all trying to do the best we can. We need to commend the doctors in Nigeria. I know they don't get enough credit, because we don't have a lot of technology. And these people are here, they didn't jackpot or all these things, They stayed back to take care of the patient with the minimal resources that they have. So we need to give them a round of applause. So we need the help of the insurance doctors to help get these patients the therapy that they need, and not stall some of these patients, because by the time you waste time and you stall, it's too late for this patient, and some of these patients might not come back. We cannot do this ourselves. We can't do this by ourselves. It's a group effort. They say teamwork makes the dream work, right? If you want to run fast, you go alone. If you want to run far, you go together. So we need to go together as medical professionals, as industrialists, as insurance people. We need to help get these patients that they need. Patients due to high risk revascularization, these are some of the things that we're going through, problems we're going through. Poor awareness. They say this patient is too high risk. We don't know who to refer to. We refer to elate. There's inadequate revascularization. I wish I could play that previous video. Some of the patients are treated up to the knee. Below the knee, they don't touch it. The reason why is because most endovascular specialists, in my opinion, in this country, most people don't want to touch anything below the knee. And the reason why is because below the knee is very, very high risk. You can convert that patient to acute limb ischemia. The arteries are small, okay? They're usually very calcified. You need to have the right tool. You need to have the right equipment to fix it. And if you're trying to fix it and you make it worse, then you turn it into acute limb ischemia. So a lot of times they don't want to touch this high-risk patient. But I've been doing this a long time, and and I'm sure we need more people. It's not just about one person doing it. We need more people to start getting involved with these things. It's not just about one person. We need a lot of people to do it so you can help the patient. But just so you know, a lot of times people will fix above the knee. Anything below the knee, they leave it alone. And it's the below the knee ones that really cause critical limb ischemia that we need to take care of. All right. Move through that. So this is a very good slide. We need to promote ABI testing. Remember aggressive cardiovascular risk factors. Treat claudication to improve functionality. Refer early and raise awareness. Okay? So you guys have done a great job. So now I want you to come with me. We're going to get into a plane and we're going to fly into some cases. All right. So we're going to talk about some of the cases that we've done. Okay? This was a case I did a long time ago, not a long time, some years ago. So as a patient, you can see the left common iliac is completely occluded, all right? Traditionally, this patient will have gone for surgery and a bypass. So I was able to fix this and put a stent, and you can see the post results. She got a 9x38 covered stent. He did very well. It was a 75-year-old man, couldn't go into surgery, and we were able to fix it, and he actually went home the same day. We had to use intravascular lithotripsy. That's where you see the IVL. So I used the 70 M5 Plus IVL. which is a way to use shock wave to break the calcium. Because a lot of times these stenosis are very calcified. And if you just go with a regular balloon and you open it up, you're going to rupture. And if you rupture it, that patient can die within minutes because it was just going to bleed into the belly. So we use shockwave electrolysis. We fracture the calcium, and then you can put the stent. This is another one. You can see both the iliacs are gone, and we're able to reconstruct it, and it looked nice. So this is a nice video, so you can watch what we're doing. This is a patient that had external iliac artery stenosis. You can see over here. This is the balloon. As we're blowing up the balloon in the external iliac artery, see pops. And then we're putting the stents. So now you can see it's fixed. Right? Actually, we use a balloon expandable stent. I use a balloon expandable stent there. You can see the before and after. That was the case I was telling you about. This is a patient with a right common femoral artery stenosis. You can see this is the acetabulum. This is the head of the femur. You can see the common femoral artery over here. And we did an atherectomy. No stent, just atherectomy. And you can see the result, almost a 95% resolution of the stenosis. This patient didn't have to go to surgery. And you can see the stenosis was right next to the inferior epigastric artery. The inferior epigastric artery is the demarcation of the pelvic area. So anytime you're doing your catheterization, if your puncture is above that, you know that the patient can have RPH, which is retroperitoneal hemorrhage. So this was a kind of tough, but we did it, and it was great. Patient was happy. Now, this is a patient with complete left superficial femoral artery occlusion. I'm going to play the first picture of the first video. You can see the blood is stopping there. So the whole SFA was gone from the beginning. And the only thing that the patient had, I'm going to go back, was the profunda. You can see right there, completely blocked. And this is what happens after we fix it. And this is another one. Was a very, very tough case. You can see I've labeled everything. You can see the SFA. You can't even see the knob. You cannot even see where it starts from. And that's a very, very tough case to do, typically. And I was able to fix it. And you can see now the SFA is open with a stent. But a lot of times, if you can't see the knob, you don't know where to puncture. And, you know, if you just start puncturing everything, you're going to start bleeding into the patient's, you know, and cause compartmental syndrome. This is a patient that we did in Lagoon. I don't know if the patient is around, but anyway, he had a popliteal blockage. You can see very, very elastic lesion right there. And we're able to fix it, and his symptoms were completely gone. And I hear he's still asymptomatic, right? Okay. This is, I think I did this my last 2 weeks ago before I came. Patient with complete anterior tibial artery CTO, right from the beginning all the way to the foot. Those are the ones that are very difficult, they're very diffuse, very long, very calcified, and the patient was having rest pain. And you can see the post picture. The anterior tibial artery is completely open now all the way to the foot. This is another patient with anterior tibial artery CTO. I used an atherectomy device in this patient because there was a lot of calcium and nothing was going through, and you can see the post pictures look great. This is a patient that had almost everything gone. You know, the peroneal is gone, the anterior tibial artery is gone, the posterior tibial artery is gone, and we're able to fix all three of them, and you can see everything looks very nice here. This is a tough case. This is a patient with a TP trunk. The tibial peroneal trunk was completely gone, as you can see here. So the patient is coming. You have the popliteal artery. Right here, you have the just collaterals, and then the collaterals are feeding the peroneal and the anterior tibial artery. So what happens is when you try to fix this, if you knock off the collaterals, then you turn that patient to an acute limb ischemia, and they have to cut off the leg. So, but we're able to fix it, as you can see, and everything is going, you know, you can even see the wire in there. We was able to get it open, and that saved his leg from getting an amputation. I think this last picture, this is a patient we had to reconstruct the pedal arch. not reconstruct, but we have to fix the pedal arch. And you can see blood is now flowing through the arch and going all the way back to the leg. So thank you for your attention. You guys have done great.
Thank you, thank you, thank you. Thank you so much, Professor Badero, for that was expository. It took us from and took us to, it was a real journey we went with you, seeing the miracles, so to speak, that you are performing in your field. And it reinforces the fact that when the patients are diagnosed early, co-managed appropriately, referred appropriately, treated promptly, remarkable outcomes can be achieved. And so at this point, we throw open, see there, so there, people are already, we throw open the question and answer session. We'll try and make the questions, short, brief, concise, and as complete as possible within that period. So, Prof has been on his feet for over an hour. I think we can try so that he can get a seat shortly. Thank you very much.
All right, thank you very much. Prof, well done. Fantastic talk as always. Just a brief point. Thank you so much for organizing this, and to Dr. Kuro as well. The main, I think, message that we really want to send out here is this message of increasing awareness. Certainly, I'm not somebody who does these types of procedures, but I see the aftermath of these procedures, which is these patients who are requiring amputations. And we've seen too many of these patients. They come, and it's always such a disaster. They turn up, it's too late. The leg is essentially gone, and you just the only option you've got left is to cut it off. And the critical thing that I think maybe an additional take-home message we can all have here is that when the patients come early, it is the hardest time to convince them to do anything, because they don't feel anything. They feel like it's not dramatic. To the caregivers, they feel like, oh, it's not that bad. Why are they talking about doing all these invasive, fancy things or whatever? But that's where the benefit is greatest, is when it is at that very early point where the patient is still not yet critical. And by the time they are convinced that there is a problem, like, oh my God, look at my leg, or look at their leg, it's terrible. At that time, it's too late for us to help them. So thank you again for organizing this talk and sort of raising this awareness. And we'll still need to do this really hard work of convincing the patients when they arrive early that this is the best time to intervene and help save limbs and save lives. Thank you.
All right, I just want to respond real quick. Sorry. So, Dr. Majakurumi, thank you for that information. Actually, you're actually very correct. You know what they say something. They say, if you don't respect information, you will suffer deformation. If you don't respect information, you will suffer deformation. The difference between distinction and destruction is association. The difference between distinction and destruction is association. So you have to associate yourself with the right people. This is what we're trying to do. And we're trying to give the patient information. You know, you always have to be positioned to be found and packaged to be bought. So we have to position ourselves to be found and packaged to be bought. So they understand what we're trying to give to them, and then they buy into it. So thank you for your time.
Thank you very much. The two doctors here were holding my hand so that I don't faint when you were saying, pad, they die, they die. I was saying, oh God. The doctors were telling me, don't worry, it's for those who are not being taken care of. You are under control. I said, okay. Thank you. I think we need to change the message, the awareness. I have been doing advocacy. I know PAD is dangerous, but I didn't know the danger. And I'm not speaking for my doctors, but I don't think most of them know this danger like you presented it now. I'm scared. I'm going to see my cardiologist. I'm going to see my endocrinologist, my pediatrics, everybody I'm going to see, because I don't want to die. Thank you. Please, there's just one thing I want you to change in everything. You keep referring us as diabetic patient, diabetic. The language has changed, please. Globally, we are referred to as people living with diabetes. Or like me, who is aware and have accepted my credential, I'm a live experience expert. So please change that so that we don't feel you stigmatizing us with diabetes. We are not diabetic. You know, I'm Osaihoi. I'm a person living with diabetes. I just wanted to add that. So thank you very much. So what advice you give to me? Doctor, I'm going to come to your hospital. That one is setting. What advice? I want to leave because I have bad. Please.
So
You asking? But that's just what I want to say. And thank you.
thank you for the questions and the suggestion. It's noted, patients living with diabetes. But I think you're different, First of all, you're here. There's a reason why you're here, That's because you're taking the patients are in the driver's seat. We as doctors, we're not in the driver's seat. We're just co-pilots. So you're here because you want information, you want to get better, and that's a great thing. And I advise all patients living with diabetes or living with some other condition to do the same. I think you're doing a great thing. You're seeing your doctors. The only thing I'm going to tell you differently is for patients living with diabetes, don't cut your nails yourself. In the US, they don't cut the nails themselves. The podiatrists cut the nails. The reason why is because if you cut your nails yourself, you can cut yourself. And when you cut yourself, you can have an ulcer that doesn't heal. That's number one. So it's better for the podiatrist to cut the nails so that you don't cut yourself. So the second thing is don't walk around the house barefooted. Because patients living with diabetes, they can have neuropathy. When I see my patients in the United States, I tell them there's 6 major conditions or complications that patients living with diabetes can have. And you need to have that conversation with them each time they see you. Going from top to bottom, the first thing is a stroke. You need to make sure you're checking for a stroke. Diabetes has increased risk of stroke. The second one is retinopathy, so eye problems. Diabetes can lead to blindness. Your doctor needs to check the back of your eye to make sure there's no diabetes in the back of your eye. The third one is heart attack. In patients living with diabetes, heart attack is mostly silent. They don't feel the pain. The reason why they don't feel the pain is because diabetes damages the nerves. It causes neuropathy. So they don't feel the pain. And especially in women, they have atypical symptoms. They might not have chest pain. They might have indigestion or back pain. The fourth thing is kidney disease. Diabetes is the #1 cause of renal failure worldwide. So it is not enough for you to see your primary care doctor. Every time you see a doctor, ask, what is my kidney function? They need to tell you the number. What is the number to your kidney function? The fifth one is peripheral vascular disease or poor circulation. And the sixth one is neuropathy, which can be confused with critical limb ischemia or numbness because it typically happens at night. So in your case, make sure you don't walk around barefooted. Why? Because if you have neuropathy, you're not going to feel anything. You can step on a nail and it might cause an ulcer. And don't cut your nails by yourself. Make sure you see your diabetic doctor, your endocrinologist. Keep your appointment. Make sure you stay away, from fatty food. I always say patients with heart disease or peripheral vascular disease, they need 3 bypass. 1, you need to bypass Kentucky Fried Chicken, bypass McDonald's, bypass Wendy's. So you need to bypass all these fast foods and all these fried foods. Bake your food, cook, bake, boil. Eat more plant-based diet. It is good for patients living with diabetes. Check your A1C. Every time you see your endocrinologist, ask them, what is my A1C? The A1C tells you how good the diabetes has been controlled in the last 14 days. It's not enough for you to check your blood sugar at home. Your blood sugar can be normal and your A1C is high. You want your A1C to be less than 7. Oh, Ken is my very good friend. Oh, really? Ken is my boss. Ken is my boss. We trained together, but he was way ahead of me. He was a very nice guy. He's in Houston. Yeah, he's a good guy. Very smart. Very, very smart.
Thank you very much, Professor Badero, for that very packed and informative presentation. My question is on the pharmacology. So you did mention that some of the symptomatic treatment will be the use of antiplatelets, ACE inhibitors. Is there any place for the angiotensin receptor blockers? That is one. The other one is the study you mentioned on the use of aspirin and factor 10A rivaroxaban inhibitor, as opposed to the use of clopidogrel. Is there a reason why? There's not, or what's the effect if we had to combine clopidogrel and rivaroxaban? Because both are antiplatelet. Was there a specific reason why aspirin was the choice one to combine with factor 10 inhibitor as opposed to clopidogrel?
All right, good question. I'm sorry, what's your name again?
My name is Okogun, Dr. Okogun.
Dr. Kogan, thank you for that. So the first question is ACE or ARB. You know, in patients that are intolerant to ACE, you can use ARB. So some patients have cough and, you know, whatever. So you can use an ARB. They, you know, usually interchangeable, even in the coronaries. So that's, you can use any one of them. But the studies have been done with ACE, but you can use ARB. The second question is because of the study that I told you that was done, the two studies, the Voyager trial as well as the Compass trial, and they used rivaroxaban and aspirin. And that showed there was, you know, advantage in terms of limb events was reduced in those patients that had rivaroxaban and aspirin in the Voyager trial. And that Voyager trial looked at patients that had PAD, that had revascularization. And after revascularization, they put them on those, and they noticed that rivaroxaban and aspirin did better than just aspirin alone. Clopidogrel was not using that. Now, in the Compass trial, they looked at patients with MI, all comers, PAD, MI, cabbage, all types of patients, right? And rivaroxaban and aspirin was better. And then they did a sub-analysis with patients that were already on clopidogrel and patients that were not on clopidogrel. And the benefit was still there, which means you don't necessarily need clopidogrel for the benefit that was seen, right? Because if clopidogrel was not there and you still saw the benefit is not due to clopidogrel, it's due to rivaroxaban and aspirin. And you don't want to use triple therapy if you don't need to, because in those studies, I didn't talk about it, but there was some bleeding, even though the bleeding was not very, very significant. But when you use triple therapy, the patients are prone to bleeding. So if you need to use one antiplatelet, it's better to use aspirin and rivaroxaban because that's what has been shown in studies. And we do practice evidence-based medicine. Please, can you give Prof a good, you can't give him a very good, give him a good, can you give him my mic? Give him a good mic.
Thank you very much for the presentation. Now, coming back home in Nigeria, we have a lot of challenges. One is that vascular surgery, the most curriculum in medical schools in Nigeria is not taught. It's not included. And like you said, without information is deformation. So most of these patients, when they present, they're not picked up on time. The ones that come to us are in Rutherford 5 or 6. And most end up with orthopods amputated. Occasionally, we see very few. I think I was starting the discussion with Dr. Adebayo and Dr. Suga just today. That we had this patient that came, I think, February. The grandkids noticed that the right leg is very cold, and they told the wife. The wife got informed. Who happened to be a retired nurse, and you know something is wrong. One said, no, there's nothing wrong. My leg is okay. Said, no, the leg should not be cold. This cold, and lo and behold, they came, and then we did the CT angio at Lagoon, and found out there were clots in the SFA. You know, we took her that day. We took the following day. We took the patient in and did a focal embolectomy. A lot of clots came out. Now, what are the challenges? There was a delay in approval consumables too is a challenge. Then a majority of these patients will have benefited from interventional, than surgery. Because doing surgeries for them, you are going to destroy the collaterals. And you lay a good graft, but the leg will still go to the orthopod because you're going to get amputated. So the knowledge of vascular surgery is not available in most medical schools. I'm sure there's no doctor here that will say, okay, when I was in medical school, they taught us management of peripheral arterial disease. If you are here, raise up your hand. Dr. Egbe will give you $1 million. I promise you, if you are here and they taught you, I will tell Dr. Egbe, they will give you $1 million. So that is one thing. Then two is the consumables. No, they are not available. And of course, don't forget that the experts are never available at all. So these are the challenges facing this practice. And then even the consumables, when they are available, they are very expensive. Patients cannot afford. Most insurance companies run away from it. So these are the challenges. How we are going to go over this, I leave it to you. Thank you very much. Once again, thank you for the presentation.
When a professor gets up to ask a question, it can cause palpitations in people around. That's a very loaded question. So anyway, Professor Ogunle, thank you for that. It's a wonderful statement. So he mentioned something very important, that when they're doing surgeries, the collaterals are gone. Sometimes we don't realize that. And that's a very important principle, especially when you're doing endovascular techniques, because those patients have collaterals that's keeping the legs open. So we try not to affect the collateral. That's why some of these procedures can be high risk, especially below the foot. Because once you knock off the collateral, especially when you have a CTO and there's a collateral that is feeding it back, you don't want to tamper with that collateral, because once you tamper with it, then you're in trouble. So I think this is a call to action. I think also we need to have a patient advocacy group. It's not just about the doctors and the, just like a wonderful, I don't want to call her a patient, a wonder person, attendee. I think we need to give her the actual, the task of getting more people, I don't want to call them patients, involved, so that, because patients, they're very, very powerful in, making a difference, especially to this insurance company. So I think that what insurance companies can do, see, the thing is, if you don't pay for these procedures and the patients get amputation, you're going to pay more money. It's going to cost you more to get them a prosthesis and, how to give them physiotherapy and, you have to vocational realignment and things like that. How do they become productive? How do they go to work and things like that? So in my opinion, I think it's like penny wise, pound foolish. If you don't spend the money now, you're going to spend the money at some point, And they just need to find a better way to make this work with patients. In the United States, they cover maybe 95% and, and tell the patient to cover a certain percentage or whatever. They can tell the patient you have, 2 or 3 opportunities to get procedures in a year. So to limit, the money spent or things like that, I don't know. In terms of the consumables in Lagoon, I bring the consumables all the time I'm coming, because some of these consumables for peripheral vascular work are not available in Nigeria. And it's something that I do to help so that, the cost is less, so that the patients can get these procedures done. So it needs all hands on deck. We can all find the consumables. We can raise the awareness. The vascular training, when I was in medical school, we only had maybe 1 or 2 cardiovascular surgeons or 3 cardiovascular surgeons in the whole country. They were not even doing open heart surgery because there was no cath lab and nobody was doing angiogram. But now we have good cardiovascular surgeons around. So the hope is eventually we're going to have vascular surgeons around. If anybody knows a vascular surgeon that is Nigerian, is trained, this is the time to come back to Nigeria. This is the time to get involved. This is the time to help people. Because if you draw a circle, you cannot complete the circle without coming back to the beginning. So this is where we all began, and this is why I got involved to get back to the country. So if vascular surgeons are watching this anywhere, they need to get involved, involved with the platform, with the hospital, and we need your services here. We cannot do all these things alone. But thank you, Dr. Professor Ogunle, for that.
Thank you, thank you, thank you. Thank you for staying till this part of the program. We can have the conversation later. Let us just wrap up now. Thank you very much. So I'd like to invite Dr. Iwosan to the stage to present a small token of appreciation to Professor Ourotimi Badero. You'll need to come up the stage. You need to hand that to her. Thank you. Our media team ready? Yes. So this is our token of appreciation for you coming back home to complete that circle and collaborating with Iwosan Lagoon hospitals to achieve that dream. Thank you very much, sir. I'd like to welcome to the stage Dr. Oluyemisi Odubayo to present the next token of appreciation to our panelists that shared with us from their expertise that have accumulated over the years. So we'll start with Dr. Adeboyega Alao. Thank you for honoring us with your time today. We appreciate you. Open up here. Kindly join us on the stage. No, not me. Me. Another one. Dr. Sir, you're presenting all the rest. Dr. Francis Asogwa, please join us on the stage. The next one. Thank you very much, sir. Professor Bolaji Mofikoya. Thank you very much, sir. Dr. Ikido Opiabele. Thank you very much, Ma, for honoring us with your time and your expertise. Dr. Grace Akere Dolu. And now I'd like all the panelists to join Dr. Iwosan Kuyoro, Professor Badero on the stage for a group picture. And then I'd like to get the representative of JNCI to please come on stage and address us for just a minute. Thank you. Please, can we have the group picture? Dr. Kuyoro? Yes. Please, can we have all the panelists on the stage, please? A quick picture on stage. Thank you. Yes, on the stage. Sir, please. Can just have the team. Thank you very much. Thank you very much. So the representative from JNCI, please, you have 1 minute to address the room. Sorry.
Hi, everyone. Good afternoon. Good afternoon. Thank you for your time. And I really want to appreciate everyone for being here since morning. I want to especially appreciate the management and staff of Iwosan Lagoon for this great opportunity. It has been an eye-opening. Actually, I've learned a lot. My name is Oluwayemisi Adewoye. I'm a clinical application specialist from JNCI, and everything that has been said since morning is actually what we align with and what we support. JNCI is a medical equipment solution company. We are healthcare projects solution company. I heard about vascular grafts, stents, and others. JNCI has actually partnered with a Swedish company. The name of the company is Gettinge, and all those consumables are actually available with JNCI. And we've been talking about PAD since. We've talking about peripheral artery disease. We are in partnership with this initiative. We brought a duplex ability, a machine made by Huntley. A lot of people have been there having their tests being run by us. So if you're interested in having your PAD checked, you want to know your level of peripheral artery disease, there's a machine there for you. You can just walk up to us. So, and we want to really appreciate, and I've not been able to ask the question, please. I know JNCI was part of federal government initiative in some years ago in equipping federal hospitals across Nigeria for ICU. And I noticed a lot of ICU does not have even the machines that are required for checking peripheral artery disease. We see a lot of patients that they are just there, they're on compression therapy. And when we make inquiries, nothing is being done to actually know whether they are compressible or not. So I think that is one of the things that needs to be put in place in terms of our ICU and a lot of things. And also, I don't know if somebody will ask this question, answer my question finally. I was not able to ask. So please, whenever we go on our training, because I'm a trainer, when we do vascular assessment, we see that a lot of arteries doesn't have pulse again. But peroneal artery always still give us some pulse in a diabetic patient. I just want to know what's the uniqueness of this particular artery. Thank you so much, everybody. We are happy to be here with you.
Thank you, thank you, thank you. So at this point, we are wrapping up our program, and it will soon be networking. But I'd like to invite Dr. Ayobami Kuyoro up to the stage to give her vote of thanks as we come to the end of this.
Thank you. Before I give the vote of thanks, I'd like to invite Dr. Olatokunbo Useni, moderator for today, on stage for our own plaque. I'm sure we can all attest that she did a fantastic job engaging us. From 12 noon till now, she has been very engaging. Thank you, Doctor. Good afternoon, everyone. If I can just have your attention for 2 minutes. So as we bring this exceptional forum to a close, I'm sure you all agree with me that it has been exceptional. I do so with immense gratitude and a renewed sense of purpose. One house, please. Today's discussions, you agree, have been far more than an academic exercise. They have been a powerful reminder that behind every diagnosis, every intervention, and every innovation in medicine lies a human life, a family, and a future that depends on our collective commitment to excellence. To our keynote speaker, Professor Ourotimi Badero, we extend our deepest appreciation. Your passion for advancing endovascular medicine and your commitment to improving patient outcomes have inspired us all. Thank you for sharing not only your expertise, but also your vision for what is possible when innovation and purpose come together. To our distinguished panelists and moderator, thank you for lending your voices, your experience, and your perspectives to this important conversation. The richness of today's discussions is a testament to the power of multidisciplinary collaboration in shaping better outcomes for our patients. Well, we were to have a patient here come and give us his own personal testimony, but he couldn't make it. So I also like to express my appreciation to our CEO, Dr. Olubisi Oyeniro, for his commitment to clinical excellence, continuous learning, and initiatives that advance specialist healthcare within our organization. And to our group CEO, Mrs. Folalawe, thank you for your visionary leadership and your steadfast commitment to building a healthcare institution that continues to raise the standard of care and create platforms such as this for learning, collaboration, and innovation. I also like to recognize my fellow managing directors. Dr. Odubayo is still here, whose partnership and support continue to strengthen our collective pursuit of excellence across the group. Now, to all our guests, thank you. Healthcare professionals, partners, and stakeholders, thank you for honoring our invitation. We appreciate it. It's not easy to have doctors, sit down for 3 hours, away from your practices. We say thank you. And your presence today demonstrates a shared commitment to advancing healthcare and improving outcomes for the patients and communities that we serve. And finally, last but not the least, I'd like to extend my appreciation to every member of the organizing committee. Daria and team, the marketing team, thank you so much for putting this together. And to everyone, that worked tirelessly behind the scenes. A lot of people work together, to make this happen. And I'd like to thank them. Because indeed, excellence is never achieved alone. It is a result of collaboration, dedication, and shared purpose. So thank you. And as we live here today, you are not listening. As we live here today, may the conversations we have had not end within these walls, please. I think that's the most important thing. Yes, let it not end here. May they inspire new ideas, stronger partnerships, and renewed determination to transform the future of vascular care in Nigeria and across Africa. So thank you once again for your presence, your contribution, and your commitment to excellence. And I wish you safe travels back home. And thank you for coming today. We will look after you. Thank you.
Thank you, thank you, thank you, thank you for that wonderful vote of thanks. And now, I'd just like to acknowledge the presence of the representative of the president of SoftPond. We had called earlier, Dr. Dada Tayoshe. I don't know if you're still here. And Mrs. Osareko Chima Wogugu. Osareko. Yeah. Chima Wogugu, welcome. Thank you for being here. Thank you for staying till the end. We appreciate you. And our appreciation goes to all the healthcare professionals in the room for starting the program with us and coming to the end also of this program with us. We appreciate you. And so we declare the networking session open, open, open.